Doctor. Good morning, doctor.
Good morning. Good morning. All the doctors are, I'm saying good morning back from all the doctors present here today. Okay.
Yeah, Dr. Badgandhi, you may start.
May we start? Okay. So, good morning, everyone, and welcome to this session, which is being hosted by the Multiple Sclerosis Society of India, Mumbai Branch. And we are always very happy to have Dr. Anita Patel and her team with us to tell us about the urinary problems faced by the patients patients with MS, and also how do we how do we go about managing these problems. Now, it's my honor to be introducing the three doctors who are going to take us forward in this session on urinary problems in multiple sclerosis. To begin with, of course, we have Dr. Anita Patel. She is a urologist to go to for all MSSI patients. For MSSI Mumbai chapter, where we always trouble her with questions and seek her advice, and she's always there for us. Like we have an upcoming camp now in Shushusha on the last Sunday of February, and I know Anita will be the first person there for this camp. Now, the areas of interest that, as I see it, Anita, is that you are past master at endourology. And I think urinary tract dysfunction is something that you are quite passionate about, both in females as well as males. And we're so happy that you have been guiding our MS patients. Now, Anita, I'll just quickly introduce your teammates as well. Dr. Sanjay Pandey, we welcome you to our session today. I've been looking at your CV, and you've had a lovely journey across India, right from Odisha, which is your hometown, through Cuttack to Vellore and Pondicherry, and now Chennai, and being one of the larger cities, and Mumbai. I'm sure you've been to Mumbai as well. And the wonderful part that I see is that you have a very exciting career in robotic urology, and that's the new kid on the block, and is really helping a lot of patients in getting quick and fast surgeries done. And of course, you had a load. You have actually a great volume of work which you have done in incontinence and in nocturia, in enuresis, in all the problems that really trouble people. Next, Javed, I'm not seeing the screen. Huh? Is the screen on? Javed?
Yeah, the screen was on.
Can you give me Dr. Sanjay Pandey's, can you put that up, please, on the screen? We saw Anita's. Yeah, that's nice. So Sanjay, welcome. And you're doing a great job. And we're so happy to have you here with us, because I'm sure you're going to share a lot of inputs, give all our MSPs, that is, our members with multiple sclerosis, and tips on how to manage their urology problems. So I think that's wonderful. And like I said, you have such an exciting career in robotic urology. I'm sure you'll tell us a little bit about that too. Javed, if you could please give me Shruti Pandit's screen, please. CV on her screen. Shruti, I welcome you. I think you're the youngest member here and in your team, but you are very, very welcome to our seminar. And you are a consultant urologist, and of course, you've done a lot of work in female functional urological problems, and that is exactly what our MSPs do suffer from. And I'm sure we're all going to gain a lot from your insights and from what you are going to tell us how to manage these problems, which are embarrassing and extremely, I would say, difficult for my MSPs to tackle. So welcome all three of you, and I hand the platform to Anita to conduct the further proceedings. So Anita.
Yes. Good morning, everybody. Is my screen seen?
Yes, Anita, I see.
Great. Thank you so much. So good morning and welcome to everybody who is joined in this meeting today. At the outset, thank you so much, Multiple Sclerosis Society, for allowing us to share some of our knowledge with the patients, because ultimately the patients have to be benefited. And that is why we are jointly working together. Today with me, we have two more faculty members, and they've been formally introduced already. Needless to say, they both are experts in their chosen field, both Dr. Sanjay Pandey from Kokilaben Dhirubhai Ambani Hospital, Bombay, and Dr. Shruti Pandit, who is joined all the way from Nagpur. And they will be answering various questions that the multiple sclerosis patients will have. And together, all of us will take this session further and make it interesting for the next 1.5 hours or so. So, what are the urinary issues in multiple sclerosis? Let's first look at that. So, multiple sclerosis, as I think all of you know, is a disease characterized by patchy loss of myelin cover. Myelin is a fatty cover on the nerve fibers, both in brain and in spinal cord. And there is a higher preponderance or higher proportion of women who are likely to suffer from MS. And it affects multiple bodily functions, and of course, urinary tract is one of those which is impacted by multiple sclerosis. In urinary tract, the disease primarily affects the urinary bladder. The nerves supplying the urinary bladder are impacted because they lose their myelin sheath too. And this leads to two types of problem. Patients with multiple sclerosis struggle to hold their urine, and they struggle to empty urine also. So before we talk about MS urinary bladder, let's see what the normal urinary bladder does. So this is my line drawing of what a happy urinary system is. At the bottom, as all of you will see with my cursor, is the normal urinary bladder. It's a smiling bladder. That means it's functioning normally. The two tubes which are shown vertically here are the two ureters, or the tubes conducting urine from kidney down to the bladder. And on top are the bean-shaped kidneys. And if the bladder is functioning normally, that means if it is happy, the kidneys and the entire urinary system will be happy. As against that, if the urinary bladder is not functioning well, the entire urinary system and correspondingly, the health of the person can actually go for a toss. Adding fuel to fire, there are two major differences in the way men and women pass urine. Men usually pass urine in standing position. Their urinary tract is anatomically different. Women primarily pass urine in sitting position. And the problems faced by women and their urinary tract are a little different from those suffered by men. So normal urinary bladder has two main functions. It must store safely at low pressure without any leak. But we are all the time aware that yes, urinary bladder में पेशाब भर रहा है. I'll be switching languages periodically because as I understand, यहाँ काफी सारे patients हैं जो कि हिंदी में बात करते हैं. So as the bladder fills up, we go on realizing कि yes, पेशाब की थैली भर रही है. At some stage, urinary bladder gives us a signal कि भाई जाके आओ, नहीं तो प्रॉब्लम हो जाएगा. So bladder is constantly sensing that. Along with that, when we eventually go and pass urine, the bladder must empty completely. The pressure in the bladder should be low. The urine flow should be steady. And at the end, we must be satisfied that हमने पेशाब पूरा किया है. और ये पेशाब करने की क्रिया यूरिनरी ब्लैडर कितनी भरी है उसके ऊपर नॉर्मल लोगों में इतना डिपेंड नहीं रहता है. 10 ml भी पेशाब हो हम खाली कर सकते हैं. 300 है तो भी खाली कर सकते हैं. 500 है तो भी खाली कर सकते हैं. दैट इज प्रोवाइडेड द यूरिनरी ब्लैडर इज वर्किंग नॉर्मली. और ये सब पॉसिबल है क्योंकि ब्लैडर अपनी ब्रेन के साथ कम्युनिकेट करती है थ्रू अ नेटवर्क ऑफ नर्व्स. ये नर्व्स दो तरह की रहती है, सिंपैथेटिक एंड पैरासिम्पैथेटिक, जो कि ऑटोनॉमिक नर्वस सिस्टम की नर्व्स है. सिंपैथेटिक नर्व्स हमें स्टोर करने में मदद करती है, पैरासिम्पैथेटिक नर्व्स हमें पेशाब करने में मदद करती है. ये सभी नर्व्स का कोऑर्डिनेशन सेंटर अपने स्पाइन में रहता है, यहाँ सेक्रल स्पाइनल कॉर्ड. और यूरिनेशन का सेंटर ऊपर ब्रेन में रहता है, पॉन्स करके एक जगह है, वहां से कोऑर्डिनेशन होता है. फाइनली हमारा जो बड़ा ब्रेन है, फ्रंटल लोब, वहां से हम सिग्नल्स देते हैं कि अभी आप टॉयलेट में गए हो, अभी दरवाजा बंद किया है, आपने कपड़े उतारे, अभी राइट टाइम है पेशाब करने का. जस्ट इमेजिन अगर ये सब सिग्नलिंग सिस्टम डिसरप्ट हो गई तो मतलब पेशाब के सिग्नल ना तो ब्रेन तक पहुंच पाएंगे, और अगर वो पहुंच भी गए तो ना तो ब्रेन उन्हें प्रोसेस कर पाएगा, और वेरी ऑफ्टन ब्रेन का दिया हुआ सिग्नल ब्लैडर तक नहीं पहुंच जाएगा. And all this happens in multiple sclerosis patients primarily because the myelin sheath covering the nerves is impacted. So signal transmission is impacted. Not only that, with age, there are certain changes happen to both men and women. Here for representation purpose, we have taken a female body. But just as all of us age, multiple sclerosis patients also age. So the age-induced changes will happen even in multiple sclerosis patients, just as they will happen in patients without the disease. So that, along with MS together, can actually create havoc in patients with multiple sclerosis. So क्या होता है MS के patients में? First of all, पेशाब की स्टोरेज करने की एबिलिटी कमजोर हो जाती है. मतलब हम कम पेशाब जमा होने पे ब्रेन को सिग्नल गलती से भेजा जाता है कि भाई बहुत तेज पेशाब आया है. सो वी गो फ्रीक्वेंटली, फ्रीक्वेंसी बढ़ जाती है. नॉट ओनली दैट, फ्रीक्वेंसी के साथ अर्जेंसी, मतलब मुझे एक बार पेशाब लगा तो मुझे भाग के जाना ही है. दैट इज द नंबर 2 issue. Frequency and urgency are the commonest issues suffered by MS patients, almost 30 to 70%. A relatively uncommon complaint is inability to empty at will. मतलब जब भी मैं चाहूं तभी मैं यूरिनरी ब्लैडर खाली कर सकूं. ये MS के पेशेंट्स में नहीं होता है. रफली 30 to 40% of patients also suffer with inability to empty. जैसे मैंने पहले कहा, इसकी दो वजह है. एक तो ब्लैडर गलत टाइम पे सिग्नल भेजती है, भेजने के बाद वो पेशाब रोकने का जो सिग्नल है वो ब्रेन से ब्लैडर तक नहीं पहुंचता है. As a result, the person goes frequently and sometimes there is a leakage of urine. दूसरा प्रॉब्लम होता है कि ब्लैडर एम्प्टी होनी चाहिए, ब्लैडर का सिग्नल ब्रेन तक नहीं पहुंचा है, ब्रेन का सिग्नल ब्लैडर तक नहीं पहुंचा है. एज अ रिजल्ट यूरिनरी ब्लैडर का दरवाजा ही नहीं खुलता है. अगर खुलता है तो वो इनकम्प्लीट खुलता है. एंड एज अ रिजल्ट द यूरिनरी ब्लैडर इज रियली स्ट्रगलिंग टू एम्प्टी द यूरिन. ताकि पेशाब का फ्लो स्लो हो जाता है, हमें जोर लगाना पड़ता है, एंड इन द एंड द ब्लैडर probably will have a lot of urine which is left behind. Very often in addition to that, टॉयलेट की मतलब संडास करने की भी शिकायत होती है, क्योंकि जिस तरह ब्लैडर इंपैक्टेड रहती है उसी तरह टॉयलेट की जगह भी इंपैक्टेड रहती है. सो दीज पेशेंट्स कैन सफर फ्रॉम आइदर लीकेज ऑफ स्टूल्स or exactly the opposite, constipation, just the way urinary tract is impacted. Associated with that, there are other problems. These patients are more likely to catch infections because they're more likely to leak urine, have wet clothes, more likely to need a diaper. So a fertile ground for infection. अगर पेशाब की थैली खाली नहीं हो रहे, बार बार इन्फेक्शन हो रहा है, तो स्टोन फॉर्मेशन की क्रिया ज्यादा आसानी से हो जाती है. However, in spite of all these problems, the good news is that MS के पेशेंट में किडनी में सीरियस डैमेज जनरली नहीं होता है, which is the only silver lining, as I would say. तो फिर MS के पेशेंट में मेन प्रॉब्लम क्या है? They impact the quality of life. The person with MS may often have to be in a diaper, may have to control their water intake so that they don't go, frequently, or they don't have the issue of leakage. Whenever they are going out, they have to map out the availability of toilets, because otherwise they will not be able to socially mix with people. So their social life is largely impacted. All their going outs are revolving around availability of toilet. कभी भी बाहर जाने के पहले हम ये सोचते हैं, अरे वहाँ टॉयलेट है क्या, अगर है तो डिसेबल्ड टॉयलेट है क्या, एक्सेस है क्या. सो सोशल लाइफ इम्पैक्ट हो जाता है. पर्सनल लाइफ ऑफ कोर्स इम्पैक्ट हो जाता है, क्योंकि देयर इज स्मेल ऑफ यूरिन, बार बार पेशाब के लिए जाना पड़ता है. एक बार आप टॉयलेट गए तो बहुत देर लग सकती है पेशाब पूरा होने में. तो घर के लोगों को, एंड खास करके आपके मैरिड लाइफ में, सेक्सुअल लाइफ में, ऑल ऑफ दीज इश्यूज कैन इंटरफियर. लास्ट बट नॉट द लीस्ट, द फाइनेंशियल इशू. देखिए, यूरिन के लिए डायपर यूज करना, कभी कभी पेशेंट्स को कैथेटर यूज करना पड़ता है, एंटीबायोटिक यूसेज है, टॉयलेट पेपर का यूसेज ज्यादा है. नॉट ओनली दैट, think of soiled clothes which you have to wash, think of the cost of water, washing powder, the tablets that you have to take. All of this is a huge financial burden on patients suffering from MS. अगर आप MS के पेशेंट हो तो आपको क्या करना है? पहले टॉक अबाउट इट. ये मत सोचिए कि चलो MS तो हुआ है, मैंने सुना है बाकी लोगों को भी पेशाब की शिकायत है, मुझे भी हो रहे हैं, मैं कैसे भी मैनेज कर लूंगा. नो, टॉक अबाउट इट, टॉक टू योर फैमिली. अगर आप एम्प्लॉयड हो तो टॉक टू योर एम्प्लॉयर्स. अगर आप काम पे जा रहे हो, आपके कलीग्स के साथ बात करिए. घर में जो भी केयर गिवर्स है जो आपको सपोर्ट देते हैं, उनके साथ बात करिए कि भाई ये पेशाब की दिक्कत है, ये मैं कोई डेलिबरेटली नहीं कर रहा हूँ, मुझे ये अनअवेयर हो रहा है, विदाउट माई नॉलेज. एंड लास्ट बट नॉट द लीस्ट, अगर आप डॉक्टरों के रेगुलर टच में हो, the doctor could be your family doctor, the neurophysician, anybody, please tell them कि भाई मुझे यूरिन की तकलीफ हो रही है. Only then we will be able to address the issue. एक बार आप डॉक्टर को मिलने के बाद वो आपकी डिटेल हिस्ट्री लेंगे, आपको एग्जामिन करेंगे, इंटरनल एग्जामिनेशन, जो कि लेडीज में वजाइनल एग्जाम रहता है, जेंट्स में टॉयलेट की या संडास की जगह से हम एग्जामिन करते हैं. उसके बाद यूरिन एनालिसिस, मतलब रूटीन यूरिन टेस्ट, एक सोनोग्राफी सभी में की जाती है, ये देखने के लिए कि इन्फेक्शन नहीं है ना, एंड पेशाब की थैली खाली हो रही है या नहीं. In patients who are going frequently, we ask them to keep a record of their urine. This is called bladder diary. And in a selected group of patients, काफी detailed test हम bladder पे करते हैं, जिसके दो component है. One is a flowmetry and one is an invasive test, जहाँ urinary bladder में हम नली डाल के कंप्यूटर इस्तेमाल करके ब्लैडर का पूरा फंक्शनिंग स्टडी करते हैं. ये सोनोग्राफी का पिक्चर दिखाया है, जिसमें प्रोस्टेट भी दिखाई है, यूरिनरी ब्लैडर दिखाई है. ये यूरिनरी फ्लो का ग्राफ है, जो कि नॉर्मल पेशेंटों में होना चाहिए. MS पेशेंट में ग्राफ अलग रहता है. और ये नीचे फ्लोमीटर दिखाया है, जिसमें एक तरह का स्पेशलाइज्ड कमोड समझो. इसमें अगर आपने पेशाब किया तो नीचे जो सेंसर बिठाया है, वो आपका पेशाब किस तरह से हो रहा है वो कंप्यूटर को सिग्नल भेजता है, और वो एक ग्राफ के स्वरूप में जो यहाँ दिखाया है, इसे हम कहते हैं फ्लोमेट्री. तो ये सोनोग्राफी और फ्लोमेट्री, ये बहुत बेसिक टूल्स है, जिससे हमें काफी जानकारी मिलती है अलोंग विथ यूरिनेशन रिकॉर्ड, कि ये पेशेंट को किस तरह की तकलीफ हो रही है. एक बार वी हैव फाउंड आउट व्हाट इज द प्रॉब्लम. जिनको स्टोरेज प्रॉब्लम है, मेनली फ्रीक्वेंसी विथ और विदाउट लीकेज, let's see what all we can do. First thing is change in lifestyle. मतलब लिक्विड इनटेक एक तो क्वांटिटी कम कर दीजिए, और उसके टाइमिंग बदल दीजिए. जैसे कि बाहर जाने के पहले तो 1-1.5 घंटा पानी की मात्रा कम कर दीजिए. रात को सोने के एटलीस्ट 2 आवर्स बिफोर प्लीज डोंट टेक एनी लिक्विड्स। फूड हैबिट्स मतलब लिक्विड्स में भी अगर एक्सेस ऑफ टी कॉफी हो या एरेटेड ड्रिंक्स हो, वो सब आपको जितना कम ले सके उतना कम करना है। नॉट ओनली दैट, आपके ब्लैडर को आपको खुद ट्रेन करना है। ब्लैडर आपको पकड़ने पहले आपको ब्लैडर को पकड़ना है। सो बिफोर द ब्लैडर सेंड्स यू सिग्नल, in fact follow a routine whereby you will use the washroom at fixed interval, maybe every 1.5 hours, every 2 hours, so that the bladder doesn't have the reason to catch you unaware, and the possibility of you having to rush to the bladder, rush to the toilet, sorry, and a possibility of leakage is very, very low. कॉन्स्टिपेशन और यूरिन का बहुत नजदीक संबंध है, क्योंकि कॉन्स्टिपेशन से अगर मोशन की जगह पूरी लोडेड है तो वो पेशाब के रास्ते पे दबाव लाता है। यूरिनरी ब्लैडर को अगर इंटेस्टाइन ऊपर से मोशन से पैक्ड इंटेस्टाइन ब्लैडर पे दबाव ला रहा है तो ब्लैडर ज्यादा फ्रीक्वेंटली यूरिन का सिग्नल देती है। तो ट्रीट योर कॉन्स्टिपेशन, जिसके लिए या तो ओरल लैक्सेटिव आप ले सकते हो या कभी कभी मोशन के जगह से सपोजिटरी डाली जाती है, जिससे मोशन ज्यादा क्लियर होने में मदद होती है। अगर आपको चलने में दिक्कत है और बार बार पेशाब आ रहा है तो स्पेशल टॉयलेट आप क्रिएट कर सकते हो, बेड साइड कमोड रख सकते हो, सो दैट ऑन द वे लीकेज होने की पॉसिबिलिटी कम है। एंड ओवरऑल, maybe with the help of physiotherapy, maybe with the help of your caregiver, increase your overall activity level. जितना आप पैरों की एक्टिविटी ज्यादा करेंगे उतनी यूरिनरी कंट्रोल ज्यादा आने में हेल्प हो सकती है। पेल्विक फ्लोर मसल जो हमारे यूरिनरी और मोशन के पैसेज को सभी जगह से सराउंड करते हैं, इट्स अ शीट ऑफ मसल विच सराउंड्स द ओपनिंग ऑफ यूरिनेशन, opening of the vaginal area in women and the bowel area in both men and women. That sheet of muscle can be trained with physiotherapy. And physiotherapy can really do wonders in patients where pelvic floor muscles are lax. If they are trained properly with physiotherapy, urinary control can be improved dramatically. Those patients who pass urine frequently, we put them on appropriate medications. All these medications come under the category of bladder relaxants. मेडिकल टर्म में हम उन्हें कहते हैं एंटी मस्कैरिनिक टैबलेट्स। और ये टैबलेट यूरिनरी ब्लैडर जो बार बार और गलत टाइम पे सिग्नल दे रही है और बहुत पावरफुल सिग्नल दे रही है, उसमें काफी फर्क कर देगी। सो दीज टैबलेट्स, सम ऑफ देम हैव टू बी टेकन ट्वाइस अ डे. The newer tablets nowadays have to be taken once a day, and as a result, the frequency improves. The urgency becomes much less, and there is a possibility that leakage may stop altogether. However, these medications do have certain side effects. Some of them can lead to dryness of mouth, but worse still, some of them can actually produce constipation. So you need to discuss with the treating doctor कि भाई मेरे situation में कौन सी tablet सबसे ज्यादा suitable है. There are patients where leakage is the main issue, mobility is not so good. So whether we like it or no, they'll end up wetting themselves. There are excellent quality diapers available. Check with the pharmacist, check with your doctors. The diapers are large in size, they have large holding power, and the fit is so good that the possibility of spillover is very low. So make sure you use correct diapers in those patients who need diapers. अगर बेड पे लीकेज सिर्फ रात में हो रहा है तो बेड का मैट्रेस प्रोटेक्ट करने के लिए अच्छे बेड प्रोटेक्टर्स आर अवेलेबल. They are available online on various sites. It could be Flipkart, Amazon. Just check that you will get a protective sheet for your bed so that सिर्फ ऊपर का शीट आपको चेंज करना है, मैट्रेस खराब नहीं हो जाएगी. Not only that, अगर पेशाब के लीकेज का बहुत ही प्रॉब्लम है और खड़े होते होते पेशाब अगर लीक हो रहा है तो बेड के नजदीक आपको नॉन स्लिप मैट रखनी है, so that possibility of you slipping in the puddle of your own urine is very, very low. In those patients who are dependent on diaper, there is a possibility of skin getting affected. Various forms of skin rashes can happen. There are barrier creams available to prevent a skin rash due to diaper. Now, this is for patients who are leaking urine. What about those who are holding urine but are struggling to empty? मतलब लीकेज तो नहीं है लेकिन पेशाब की थैली खाली भी नहीं हो रही. ऐसे पेशेंट को खुद अगर पॉसिबल है तो कैथेटर डालना सिखाया जाता है. In MS patients, that can be a challenge because some of the patients, their eyesight may be impacted. Not only that, the hand movements may be difficult. There may be hand tremor. In such patients, a caregiver can be trained to empty their bladder by what is called as intermittent catheterization. And of course, those who are catching infection, appropriate antibiotic based on the urine report. So all of this revolves around educating the patient, which is what this kind of webinar is supposed to do. So we train the patients how to inhibit the urge. Not only that, with the help of pelvic muscle training and physiotherapy, periodically keeping a bladder diary, and of course, handling your liquid intake, handling your bowels correctly, and catching the bladder before the bladder catches you, the quality of life with MS patients with urinary symptoms can be a lot better. So these are the adult diapers, and these are the catheters that we use for self-catheterization. You may or may not use gloves. You need some kind of lubricating cum anesthetic gel. So various forms of local anesthetic gels are available. And in patients where there is a possibility of repeated infections, we recommend cleaning the area with a topical solution such as betadine. Let's understand that the disease has a waxing and waning pattern. मतलब there are patients जिनका disease कभी-कभी severe हो जाता है. With correct treatment, the disease quietens down. The same pattern is seen in urinary problems. So the urinary problems can get aggravated at times, and at times they may be very silent. So not necessary that every MS patient suffers with urinary problem. But the most important message we would like to give is that even though the quality of life is altered, the urinary tract never has serious problems as a result of multiple sclerosis. That means you will not die of urinary complications of multiple sclerosis, nor will your kidneys fail, but the quality of life gets impacted severely. So unless you talk about it, the treating doctors will not be able to offer you a solution. We need a common platform to discuss this. So platforms such as Multiple Sclerosis Society and Zoom meetings such as this, they definitely go a long way in helping the patients in every aspect of this troublesome issue. Thank you so much. I'm stopping sharing my screen. Thank you so much.
Thank you, Anita. That was really very, very insightful, especially as it was it was given in a very clear and very simple matter. And, I'm sure my MSPs have benefited from this, but then we will take the question answer session later. So now if I can invite Sanjay, Dr. Sanjay, if you could, take up your topic so that
Dr. Rekha, we modified this a bit.
Oh,
and
we
I'm
have?
going to be
Okay,
asking,
sorry.
we thought we'll keep less of presentation and more of interactive question answer.
Oh, that's lovely. That's
So,
wonderful.
in fact, if there are any questions, that's wonderful. But if there are not, I'm going to be tossing questions at both Sanjay and Shruti. And I hope, Rekhatai, that's okay for you.
Yeah, that's wonderful. That will in fact make it interactive. Yes.
Yeah, they are the most commonly asked questions by patients to us, and let's have some insight and a lot of advice by experts. So, Sanjay, I'm going to be opening the question to you first. So, I am 25 and I suffer from multiple sclerosis, and my biggest issue is मैं बार बार जा रही हूँ. Sanjay, feel free. Sanjay is very proficient in Hindi, by the way. So just feel free to break into Hindi. I hope that's okay by both Rekha Tai and Sheila Tai. And Sanjay, मैं बार बार जा रही हूँ यूरिन करने के लिए और पेशाब का कंट्रोल सही है, लेकिन I don't know how to manage every half an hour I'm going. So I'm consulting you. Can you just take me through what would be your approach? मैं first time आपके पास मिलने के लिए आ रही हूँ. So just briefly tell me, how would you like to address my problem? Over to you, Sanjay.
Wonderful. So allow me a few opening sentences because this was an amazing presentation. To all respected colleagues in the MSSI and those who have joined. For you, Dr. Anita Patel has always been there, but to me, this presentation was mesmerizing. It was actually to attempt to connect to a common man who is a non-medical personnel, to be able to bring about the ideas of how much doctor is interested in your health and the quality of life that matters. Anita actually brought about an A to Z in a very crisp presentation, and it was all about that has already been discussed. We are now to breaking up into case-based aspects and taking it forward. मैं हिंदी के सिवा अब ओडिया बंगाली तमिल असमी सब कुछ टीवी पे बोलता हूं तो मेरे लिए आसान होता है ये बात करना एंड आई सॉ somebody from Chennai requesting in English, so I understand that we can actually balance English and Hindi and taking it forward. 25 years की ये युवती हैं who cannot control urine और इसलिए बार बार यूरिन पास करने जाना होता है. Remember, she's only 25. She has got 70 years to live with all due diligence to do well in the medical science. So if I look at the aspect of care, that means I need to improve her quality of life so that she continues to do well. My first take will be to build a confidence of all that she can be done in terms of happy that she spoke about it, happy that she came out of it and say, ये मेरी quality of life को disturb कर रहा है. तो हर एमएस पेशेंट, हर न्यूरोलॉजिकल पेशेंट अपने डॉक्टर के पास जाए, वो जनरल प्रैक्टिशनर हो, वो न्यूरोलॉजिस्ट हो, अपने डॉक्टर को बोले कि मेरी ये चीज तो आपने ठीक कर दी पर वो जो बहुत बॉदरसम है उसे जरा संभालिए, मैं अपनी दिनचर्या मैनेज नहीं कर पा रही हूँ, नॉट एबल टू मैनेज माई डेज. तो एज अ डॉक्टर, एज अ यूरोलॉजिस्ट इस शहर में, इस देश में, मैं, श्रुति, डॉक्टर अनीता और हमारे जितने भी यूरोलॉजिस्ट हैं जो न्यूरोलॉजी की सब्जेक्ट को यूरोलॉजी के साथ मिश्रण करके इसे ठीक करते हैं, ऑब्वियसली बातचीत करते हुए ये जानेंगे कि आप कितनी बार पेशाब करने जाती हैं दिन में और कितनी बार रात को. ये जानने की कोशिश करेंगे कि आपने कैसे अपनी दिनचर्या संभाल के रखी हुई है, क्या आप अपने टॉयलेट्स को मैप करते रहती हैं, अगर आप दादर में हैं या डोंबिवली में हैं, कैसे अपने आप को मैनेज करती हैं. अगर डर है आपको तो अवश्य आप डायपर पहनती हैं क्योंकि आपको नहीं पता कि वो सबअर्बन ट्रेन रुकेगा या नहीं रुकेगा, मैं टॉयलेट तक पहुंच पाऊंगी कि नहीं. तो दरअसल बॉदरसमनेस ऑफ क्वालिटी ऑफ लाइफ ऑफ इशू brings a individual who sadly is a patient today to a doctor to improve the quality of life on this. ये लाइफ थ्रेटनिंग नहीं है तो लाइफ को इतना इंप्रूव कर लेते हैं कि फिर हम पटरी पे आ जाएं एंड आई जॉइन द कॉमन बैंड वैगन ऑफ ह्यूमन बींग्स इन दिस सिटी एंड दिस कंट्री. सो मेरा पहला कोशिश ये होगा कि हम एसेस करें जो डॉक्टर अनीता ने अपने प्रेजेंटेशन में बताया था, एज टू हाउ डू वी एसेस दिस पेशेंट दैट शी इज स्टेबल एंड सेफ. तो एक तरफ आपकी स्टेबिलिटी, दूसरी तरफ आपकी सेफ्टी, ये दो चीजें हमारे जहन में हर समय रहता है जब आप हमारे क्लिनिक में आते हैं एज अ यूरोलॉजिस्ट. क्योंकि कुछ ट्रीटमेंट तो आपके न्यूरोलॉजिस्ट, आपके जनरल प्रैक्टिशनर बहुत अच्छा कर रहे हैं, तभी आपकी एमएस की डिजीज बिल्कुल कंट्रोल में है और वो स्टेबल रख रहे हैं. जो बॉदरसमनेस है वो बहुत बार डॉक्टर लोग मिस कर जाते हैं. तो न्यूरोलॉजिस्ट का काम सिर्फ ऊपर ब्रेन और स्पाइन में रह जाता है और बहुत बार आपने बोला नहीं. सो दैट स्लाइड ऑन टॉक, ऑलवेज टॉक टू योर डॉक्टर, रिलेटिव्स टॉक, पेशेंट टॉक, वी टॉक. ये टॉकिंग एंड अवेयरनेस टू अवेकनिंग बहुत जरूरी है. 25 साल की युवती का क्वालिटी ऑफ लाइफ इंप्रूव करने के लिए हम उनकी कंप्लेंट्स को सुनते हुए.
Yeah, Sanjay, part English, part Hindi. There are too many requests. Please talk in English. Please talk in English.
Yeah, I'm doing
So
that.
I think we will have subtitles in our
I
next.
will. I will. So we
But
will look at
let's
English.
switch. Let's switch part Hindi, part English. Yes.
Agree.
Dr.
So we'll
Anita,
look at
you
that.
may stop sharing if you don't want this presentation. You may stop sharing this presentation.
She has stopped it. Anita
I have stopped it long back.
It is still coming, Anita.
Oh, is it?
Yeah, it's still coming out. So if you can just remove it, I think they'll be.
1 minute.
So
Sorry.
you have to go down to again the stop sharing.
Is it? I have.
Yeah.
Yeah,
Done.
yeah.
Gone.
Yeah.
I'm
Gone.
so sorry.
Gone.
I am so sorry. I
So
thought I
nice.
stopped long back. Yeah.
So
sorry.
25 years young lady deserves the care that she has requested. Her bothersomeness is not taking care of her quality of life that she aspires to be in her ambition to do better. So as a urologist, we will look at assessing her. Assessment is all about looking at her safety. Assessment is all about looking at getting her better. So on one side, a confidence building and looking at how she has handled herself all this time, and then add on to all that which will improve her so that she is out of bothersomeness, which means I will always look at the way she passes urine, which means if she can control urine, which may be difficult for her to do a uroflowmetry, the way she passes urine is a graph that was shown in Dr. Anita's presentation. It gives me an idea that a young lady will have a good flow. Had it been 65 and 85, as cases would come in due course, we would look at uroflowmetry with a lot of pinch of salt. So I know that she empties her bladder well. That is what she says. I don't have obstruction to flow. I need to improve her quality of life. So then when we looked at the residual volume is low, when we look at that everything else is good, and anatomically she is still a young lady, so anatomical changes have not started yet, which happen more perimenopausal and postmenopausal. We will go directly to improve into what she has been bothered for quite some time till she landed up with a urologist. So improving her quality of life on one side will be all about beverage drinking, water drinking, emptying her bladder before she leaves for her office, empties it when she reaches office so that her work doesn't get disturbed. And if the residual volumes are good, look forward to giving her medication which would actually slow down this bladder's overactivity. ये ब्लैडर शैतान बच्चे की तरह बार बार कॉन्ट्रैक्ट कर रहा है, हम इसे शांत करना चाहते हैं. I and you are seated right now, our bladder is filling up and it is under our control. This control has gone away and the bladder gives out those powerful sensations, which Dr. Anita said, which is making you run. तो इसे शांत करने के लिए वो दवाइयाँ आज अवेलेबल हैं जो एंटीकोलिनर्जिक्स के नाम पे जानी जाती हैं, और वो दवाई देने से हम ये पूरी दिनचर्या को कंट्रोल कर सकते हैं. So because she is 25, because there is no obstruction, because she has done all that she can do in terms of drinking less water, already wearing diapers to work where she travels on a suburban train, it is important to give her the medication, build her a confidence, follow her very closely, and take her in a journey where she says, अब मैं ठीक हूँ, अब मैं पूरी ठीक हो गई. So 2 हफ्ते बाद आई, 4 हफ्ते बाद आई, बोली मैंने इतना ठीक हो गई लेकिन इतना ठीक नहीं हुई, अभी भी मैं 11-15 बार जाती हूँ. I will be then in a position to check कि हम यूरिन कंट्रोल करते करते यूरिन को ब्लॉक तो नहीं कर रहे. जब वो करते गए तो हम दवाइयों के डोजेज को वहां ले जाएंगे जहां एक इंडिविजुअलाइज ट्रीटमेंट कर पाएंगे. तो बेसिकली संक्षेप में, इट इज ऑल अबाउट इंप्रूविंग क्वालिटी ऑफ लाइफ बाय केयर गिविंग, on telling her all that she is doing and she needs to do in a more stronger, powerful way because she's so young. On the other side, giving her the right medications and tailoring it to the right dosages, which will actually take her on the journey that she seeks.
Lovely. Thank you so much. Shruti, Sanjay did speak about some of the medications. He's deliberately avoided taking names because all of us, we avoid. But could you just tell us some of the pharmacological names of some of the most commonly used preparations in a young lady? तो मतलब उनकी उम्र ज्यादा नहीं है. She fortunately doesn't have constipation. आँख में कोई problem नहीं है. So you have a huge basket in front of you of various medications that you can use. How would you, which is the most commonly used tablet that you would start? And how will you counsel her about possible side effect? अगर डोज बढ़ाना है तो वो किस तरह से कर सकते हैं? And how frequently will she have to come to show you? Let's say she started on some medication. Let's have some insight from you. Over to you, Shruti.
So good morning, ma'am. Good morning to my respected colleagues.
And I think we'll stick to English and then give a little summary in Hindi so that, everybody's happy.
Yes, ma'am. Surely, ma'am. And welcome to all the participants who've joined and to MSSI. Anita ma'am and Sanjay Pandey sir are extremely senior and experienced in their field and my personal mentors. So I'm really glad the patients have the advantage of learning from you and getting tips from you, ma'am. Ma'am, coming to your question, today we have a large basket of medications which are available to control urination. I would say control, not completely stop the leakage, but control, yes. So we use, I will mention the molecules that we use. We use tablets like solifenacin, tolterodone, fesoterodone. These medications we start depending upon what the patient really wants, what is their side effect profile, do they have constipation or not, what is their age. Depending on that, we decide what medications we want to start. In this 25-year-old young female who does not have any constipation or does not have any other vision issues, we would start with solifenacin. The usual dose is once a day, probably at night, a dose of 5 mg. And then depending on how she's responding or what is the side effect profile, we'll either change it or we'll increase it or decrease it. The most common side effect of these drugs, anticholinergics, as Sir said, is one is dry mouth. They can have dry mouth, and this actually causes more problem in the urination. What happens is वो मुंह सूख जाता है, तो you keep having more water. पानी ज़्यादा पीते जाते हैं, और उसमें आगे फिर problem आती है. So we can change the medications and see. ये solifenacin अभी सिरप फॉर्म में भी अवेलेबल है, जिनके लिए टैबलेट नहीं ले सकते हैं, सिरप में भी आता है ये. उसके अलावा अगर दूसरा कॉम्प्लिकेशन जो होता है ये टैबलेट से, वो है कॉन्स्टिपेशन. कॉन्स्टिपेशन अगर हुआ, इफ देयर इज कॉन्स्टिपेशन, लाइक मैम यू सेड, जो हमारा मोशन की जगह, लैट्रिन की जगह, vaginal area, urinary area, these are all interlinked by similar nerve fibers. So constipation will worsen the urinary problem. It can cause urinary infection and can worsen the leakage. So in that case, we would decrease the dose or change to some other medication. Other medications which do not cause this sort of constipation or something is mirabegron. It is another molecule. Also another problem which can happen with anticholinergics is that, जैसे सर ने बताया, हम वो ब्लैडर को कंट्रोल करने की कोशिश कर रहे हैं, तो इतना सारा कंट्रोल हो गया कि पेशेंट माइट नॉट बी एबल टू एम्प्टी द ब्लैडर प्रॉपर्ली. So there might be a very high residual volume after the patient has passed urine. So that is why it's very important for long-term follow-up. We have to keep assessing these patients at periodic intervals, either 2 weeks or monthly. 2 weeks initially after starting the medications, and definitely after a month for every patient. And every visit, we will do a uroflowmetry, like you mentioned in your presentation. And we will also check with ultrasound कि urine करने के बाद कितना बच रहा है, जिसको बोलते हैं post void residue, PVR. These are important things to see on follow-up, and accordingly we modify and change the dose.
So, Shruti, if I'm a patient, I've started the tablet and I have got good relief, and now my disease is quiet. मतलब जो भी treatment मुझे दी जा रही है, whatever medication, my disease is really gone into what is called as remission. Is it okay if I stop the tablets? Or do I have to continue? Can I try stopping the tablet and see, and then will I be able to restart the tablets?
So whenever we start these tablets, ma'am, before we start any of these tablets, we always try certain other conservative measures like bladder training, pelvic floor muscle exercise, जो physiotherapy आपने बताया. This pelvic floor muscle exercise, what we start, it is a muscle. If I exercise today, it won't become strong tomorrow. It takes a while for the muscle to become strong. So you can decrease the dose of medications as per advice by your doctor and slowly stop it if these conservative measures are helping you strengthen your pelvic floor. And even without these medications, you are able to control your urine simply because your pelvic floor has become strong. So yes, then we can decrease the dose slowly and then stop it if the patient is not having any difficulty. But definitely not advisable to stop the medication immediately because it will suddenly worsen that urinary leak problem. Decrease it slowly, keep assessing at regular intervals of 2 weeks to see how the patient is responding. और फिर अगर पेशेंट ने अपना अच्छे से pelvic floor muscle contract कर लिया है, bladder training अच्छे से कर लिया है, then yes, we can stop the medication. अगर वापस disease remission से बाहर आता है, if the disease worsens again, then yes, we can always restart the medications. So that is why long-term follow-up is essential. हमको आपको लंबे समय तक देखते रहना है.
You've highlighted two important things, that as the disease goes into remission, urinary symptoms can also become better, and in which case patient need not continue the tablet. And in fact, we must urge them to stop the tablets, but also have the liberty to restart if unfortunately the disease goes into a relapse. So that message I wanted to give. It's not like BP medication कि एक बार शुरू कर दिया तो lifelong चालू ही रखना है. You on your own can reduce, taper, stop, provided you are in touch with the doctor who's prescribing the medication. There is a comment in the chat box, Shruti, and that comment says that usually pelvic floor exercises will show at least 6 weeks before they take an impact, and 50% reversal will occur in 2 weeks after stopping exercise. My strong advice to anybody and everybody, especially to women, irrespective of whether they have multiple sclerosis or no, pelvic floor exercise should be a way of life. And just as we give sex education to school-going girls and boys in their, adolescence, I strongly urge that everybody should be taught pelvic floor exercises so that they are really going to be enormously helpful later in life. Whether you get pregnant, you may or may not get pregnant, delivery, menopause, especially for women. And then, unfortunately, if you are struck by a disease such as multiple sclerosis, a strong pelvic floor is going to be a boon for you. So that should be continued forever. Medication can be stopped. Do not stop pelvic floor exercises. So I am on medication, and I'm going to ask this to Sanjay, and it's too much of a good thing. So I suddenly discovered that the urine control is good, but now I'm passing less and less urine. And then I'm worried. I go visit my doctor, and the doctor, of course, orders a sonography and says that, Dekho, you're passing about 7,500 mLs and you're leaving behind 300 mLs. And which is why now apparently there is a long gap, but I'm always having a weird sensation of a full bladder. So perhaps I am a likely candidate for once or twice a day self-catheterization. I have read about it. Can you just tell me, how do I do that? How do I learn that? What kind of catheters? Any care? Is it disposable? I'm so worried. What kind of catheters are they available in Bombay? Can you just give me a little bit of a walk through that, Sanjay?
Wonderful. So thank you. On one side, we were trying to control the urinary bladder, and the control became little extra than what was required. And now I find myself, though very young, not able to empty my bladder fully. And as rightly said, the residual volume left over, which should normally be between 0 to 50, has climbed to 300 ml. And therefore, those weird sensation in the pelvis में sensation आ रहा है, pressure आ रहा है, थोड़ा दर्द भी है, और हम पूरा खाली नहीं कर पा रहे, is visible to us, which means that there is a way forward for us. The entire aspect today on discussion about the positives that we want to bring in a disease process is to bring about a balance. On one side, when you're too bothered, we treat you. Other side, we're also looking at safety. We cannot leave that amount of urine in the bladder because the red flag is you may land up with urinary infection. So वो प्रेशर को कम करने के लिए जो ब्लैडर में आपको लग रहा है एंड द सेंसेशन एंड डिस्कम्फर्ट इज ऑल अबाउट अनीता सेड दैट वी मे हैव टू लर्न अ टेक्निक जिससे हमारी ब्लैडर अगर पूरी खाली नहीं हो पाई तो उसे खाली करते हैं. Now the bladder has learned it will not contract erratically and make me run again and again to the washroom. So I'm comfortable. I'm socially comfortable. I can work on the location where I work in. But what has happened is in that background of bringing about the bothersomeness to near control, I am finding it difficult to empty. It is just not the effect of the medicine alone. It also is a part of the effect of voiding dysfunction, which happens in MS. On one side, you have got an emptying mechanism issue, which is what we talk now, which has got highlighted, not necessarily forced by the medication. Other side, the bothersomeness part is clear. So clean intermittent self-catheterization can be practiced by all of us. If we understand that, we actually in the morning take the brush in our mouth, open a mouth and brush our teeth and come out. So we use some instrument to enter our body, clean up our body and bring out. So similarly, if I want to empty my bladder, which is not emptying completely, female urethra is only 3.75 to 4 centimeters and a male urethra is 18 to 20 centimeters. All that we need to do is to be able to, without any self-harm or self-discomfort, be taught how do we take this fine tube inside, empty the bladder fully, and then be able to manage it. So कैसे करते हैं and how do we do it? Number one is we actually clean that outer part very well. I'm talking about the 24 years young girl who was the case in question. So she's young, but remember she's a female and the introitus or the urinary passage is surrounded by bacteria because of close proximity of the rectum and the vagina where there are normal resident bacteria. So we, while doing a clean intermittent catheterization, which may be required to do 2 to 4 times a day, depending on my water intake, my thirst, my body's requirement, my travel, my work, I may have to empty my bladder when I get up in the morning. I may have to empty my bladder in the afternoon when the bladder fills up 3, 4, 5 hours later, and when I have a sensation, which I've developed, maybe in the evening once and before I go to sleep at night. So before I go to sleep at night, I'll surely empty. When I get up in the morning, I'll surely empty. If required, again in the night time, which may not be required because you have got medication which has controlled the overactive bladder and you have become quite comfortable. 2 से 4 बार ब्लैडर खाली करना पड़ सकता है दिन में. खाली करने का तरीका ये हुआ that I'll clean my lower part very well, wash up, clean up, and then I will take this tube with a little bit of lubricant as Dr. Anita and Dr. Pandey and Dr. Shruti have taught me, and then be knowing where is my passage. So I know where my mouth is to take my brush. Similarly, down there we all don't know our passages. Women have the first passage as urinary passage and then the vagina and at the back is the rectum. So 3 passages. Men have an organ of urinary and sexual passage. They know how to put their catheter. So for women, it is all about understanding and knowing, and that can be done best by sitting and spreading your legs, looking at your mobile phone, doing a selfie for the urinary passage. Or in the olden era, we had mirror, which you could show me which location it is. We normally teach all this in the outpatient department to you and follow up and look at how are you doing. So hand holding the journey of self-catheterization is an important aspect of care. A urologist, a neurourologist, a rehab specialist teaches you. आप कैसे कर रहे हैं वो इंपॉर्टेंट है. आप कोई चोट ना पहुंचाएं. चोट दर्द और इंजरी की बात नहीं है, पर आप सही पैसेज में डालें और डाल करके उसको रखें, क्योंकि औरतों में सिर्फ इतना ही डालना पड़ेगा, 3.754 सेंटीमीटर डाल के रखे रहे. पूरी ब्लैडर खाली हो गई जो आपने वॉशरूम में किया, ट्यूब को निकाला, वॉश किया, अपने आप को क्लीन किया और अपने काम में लग गए. ये ट्यूब हर बार चेंज नहीं की जाती है. ये ट्यूब हम बहुत तरीके से रख लेते हैं एक स्टेराइल टिफिन के डब्बे में, और हम अगर वर्क प्लेस पे हैं, हम यहाँ से अगर नरीमन पॉइंट चले गए तो हम 4 बार अगर खाली करने की जरूरत है तो उसे बहुत तरीके से क्लीन तरीके से करेंगे. इसलिए कहा जाता है क्लीन इंटरमिटेंट सेल्फ कैथेटराइजेशन
फक्त एक विचार
या
आहे तो
क्लीन इंटरमिटेंट कैथेटराइजेशन बाय अ केयर गिवर. एक एल्डरली औरत में जो अपना खोज नहीं सकती, जिनकी आंखों की रोशनी, जिनके हाथ की डेक्सचरिटी नहीं है, उनको अगर खाली करना है तो ये तरीका है। पुरुषों में खाली करने का तरीका हुआ, उन्होंने अपने ऑर्गन को क्लीन किया, स्किन को पीछे किया, अच्छे से वॉश किया, और उसके बाद टिप को खींच के उसके बाद लुब्रिकेशन डाल करके धीरे धीरे अपनी पेनाइल ऑर्गन में कैथेटर को डाला। और ये सब कुछ वॉशरूम में कर रहे हैं, जरा सारा यूरिन खत्म हो गया अगले 3-5 मिनटों में। और फिर आप अपने आप को कंफर्टेबल पाए, अगले 3-5 घंटे में ब्लैडर फिर भरने की कोशिश करेगा, हमारी कोशिश होगी फिर से हम खाली करें। तो ये कैथेटर्स अवेलेबल हैं। ये थोड़े फाइन बोर छोटे साइज के कैथेटर होते हैं, इससे कोई पीड़ा या दर्द नहीं होती है। जैसे आपने अब बचपन से ब्रश करना शुरू किया, अब कोई दर्द नहीं होता जब आप ब्रश करते हैं, वैसे ही आपने एक बार कैथेटर डालना सीखा, फिर आप माहिर हो जाते हैं, फिर आप हमें सिखाते हैं, जो हमने आपको सिखाया आप उससे अच्छा करते हैं। तो कहने का तरीका ये था कि सेल्फ कैथेटराइजेशन एक बहुत ही अच्छा तरीका है। हमें ब्लैडर तो खाली करना पड़ेगा, किडनी का काम है पेशाब बनाना, वो ब्लैडर में लाती है, उसके बाद खाली करने का काम हमारा है। और वो खाली करने की विधि में जो भी गड़बड़ हो रही है, वॉट एवर डिसफंक्शन इज हैपनिंग इन द बैलेंस बिटवीन एम्प्टिंग एंड स्टोरेज, is what we need to empty. So the catheters are available. They are sometimes disposable, which are available. Many a times it can be reused, but reused with a lot of caution, lot of understanding, which your doctor teaches you. For people who live in peripheries, who live in smaller towns, suburbs, जहाँ इतने कैथेटर नहीं ले सकते, इस कैथेटर को रीयूज करना पॉसिबल है। तो ये सब कुछ डॉक्टर इंडिविजुअलाइज करता है ट्रीटमेंट को। ये एक जनरलाइजेशन है जो हम आपको बता रहे हैं, बिकॉज ये सब कुछ पॉसिबल है। इससे आपकी क्वालिटी ऑफ लाइफ संभल जाती है। बहुत बार अगर बहुत बेड रिडन है, हिलना डुलना नहीं है, बुजुर्ग हैं, तब कैथेटर लगा दी जाती है, बिकॉज फिर 5 बार कैथेटर डालना मुश्किल है वगैरह वगैरह। तो डिपेंड करता है कौन सा मरीज, 25 साल की औरत और 70 साल की औरत में थोड़ा डिफरेंस होगा। कोई मोटिवेटेड है, अपने आप ही पाइप डालेगा, अपने काम में लग जाएगा। कोई मोटिवेटेड नहीं है, उनके हाथों की मुश्किल, उनके बेंडिंग पोस्चर की मुश्किल, तो कोई केयर गिवर कैथेटर 4 बार डालेगा, या फिर कभी कभी इनड्वेलिंग कैथेटर रखा जाएगा, और फिर इसको डिस्कस करेंगे कैसे कैथेटर को यूज करा जाए।
Lovely. That was really comprehensive about not just intermittent cath, but also about an indwelling long-term catheter, जो कभी-कभी MS के patients के लिए जरूरी हो सकते हैं. There was a question about double voiding. Could you just, especially for female patients, double voiding is a technique which is definitely worth trying before we jump on to intermittent catheterization. So would you highlight a little bit about what is this double voiding, Sanjay?
So in short, if I am comfortable in passing urine, but my doctor says कि आपकी bladder खाली नहीं होती है. So when you came and we did a sonography to check the residual volume, it is not 20, 50, 75 ml, but it is holding 200 ml, 250 ml, 300 ml, something of that kind, which is bothering a urologist that इतना urine रहेगा तो infection हो सकता है. But you are young, you are fit, you otherwise are comfortable, and you are leading a great quality of life. Remember, women actually empty their urine by relaxing the pelvic floor. आप गए वॉशरूम में और आपने थोड़ा जोर लगाया, थोड़ा रिलैक्स किया, सारा ब्लैडर खाली होता है। यही नॉर्मल विधि औरतों की होती है। इसमें अगर ब्लैडर में बहुत ज्यादा पेशाब रह जाता है, तो ब्लैडर एक बार में खाली नहीं कर पा रहा। आप गए फिर से यूरिन पास करके आए, आपने यूरोफ्लोमेट्री की, आपने शायद 250 ml यूरिन पास किया, पर 250 ml रह गया। तो क्यों रह गया? क्योंकि ब्लैडर एक बार में उतना प्रेशर जनरेट नहीं कर पाई टू बी एबल टू एम्प्टी द एंटायर थिंग इन वन गो, which happens to all of us. And you saw that Dr. Anita's presentation had a bell-shaped parabolic curve. एक बार में सारा खाली हो गया। तो if you're not able to empty your urine to significantly insignificant amount of urine left over, which is 50 to 75 ml, 50, 60, 70 ml, then we would be a little worried about high amount of urine left in the bladder. So we would request you that your bladder is not able to generate enough pressure in one go. You may have to put little exertion of pressure in the lower abdomen, which pushes your bladder to push the urine out. Normally, the urinary bladder pushes urine out, but here you may have to generate some extra pressure from your abdomen, which may not be happening on the first time, even if you did. You did your best and you came back, and significant around stays back, which your doctor is worried could lead to UTI and upper tract story. So आप 10 मिनट के बाद अगली बार फिर से जब यूरिन पास करने जाएंगे, तब तक ब्लैडर रिकॉयल हो चुका है, उसको शांति और रिलैक्सेशन मिल चुका है। देन विथ अनदर पार्शियल कॉन्ट्रैक्शन ऑफ द ब्लैडर, विच में नॉट हैपन बिकॉज हमें उतनी सेंसेशन नहीं है, हमारा ब्लैडर भरा नहीं है, एब्डोमेन को पुश करते हुए जब पेल्विक फ्लोर रिलैक्स होगा, शायद उसका आधा पार्ट फिर खाली हो जाए। सो डबल वॉइडिंग इज टू एम्प्टी योर यूरिन from a very significant high residual volume to a lesser amount of volume, which is now insignificant, कि हमें clean intermittent self catheterization की जरूरत ना पड़े.
So also the other point is in some of the women assuming a squatting position, conventional Indian style. Now let's understand we are dealing with MS patients. There will be mobility issue. There will be issues related to their inability to squat. But अगर आप squat कर सकते हो, तो शायद आपका ये double voiding, especially if you are a female patient, is more likely to be successful. But squatting as a technique is easily said than done, especially for MS patients. So that may not be the most practical option. So, Shruti, now Sanjay has given great elaborate explanation on how to empty your bladder with and without a catheter. Is there a medication? I am a 55-year-old male patient और मेरा इवैल्यूएशन किया है, मैं चल फिर सकता हूँ, आई एम एबल टू वॉक अराउंड, आई एम नॉट डायबिटिक, none of those issues, but I'm leaving behind some urine. My MS is really, well under control, and I'm able to do all my activities, but I'm struggling with my urine. I have come to you. Is it possible that maybe now it's not MS, but maybe my prostate is enlarged? Or maybe it is not enlarged. Is there a medicine that you could help me with my symptoms so that without resorting to all sorts of things, maybe catheterization, maybe double, triple voiding, squatting, do you think you can do something to improve my urination? I'm 55 and my father had prostate enlargement, so I'm worried. How would you guide me?
So first thing to understand is to pass urine, we need two things. One is the pipe should be open. Second is the bladder should press to push the urine out. Either if the pipe is not opening properly, it is closed or blocked due to some reason, or the bladder is not giving enough pressure, then urine emptying will not be proper. In a 55-year-old male who already, in a 55-year-old patient, जिनको already है कि, has this doubt of prostate in mind. Now, first, what is prostate? It's one small gland which is there below the urine bladder. Urine bladder के एकदम नीचे बैठता है, and it is normally required for reproduction. It is present in all males, और जब 50 years के बाद जब हार्मोन के बदलाव आते हैं, थोड़ा सा साइज में बढ़ जाता है, and urine की जो नली है, the passage through which urine comes out might get blocked. Prostate enlargement can be treated with certain medications. उसको हम बोलते हैं alpha blockers. These are generally taken once at night. Silodosin or tamsulosin, these are the drug names. These are usually taken once at night, and they help in opening the area from which the urine flow is there. It helps in decreasing the size of the prostate. And there are also some medications which may help in increasing the contraction of the bladder. This is called bethanicol. However, it does not work as well as double voiding or clean intermittent catheterization. So first thing in this patient is to identify कि ये क्यों हो रहा है, ये क्यों ज्यादा रेसिड्यू रह रहा है, क्या ये MS की वजह से है जिसमें ब्लैडर ठीक से कॉन्ट्रैक्ट नहीं हो रहा है, क्या ये प्रोस्टेट की वजह से है जिसमें the urine is not able to flow properly. So like ma'am said in her presentation, the ideal test would be a urodynamic study, जिसमें we will know exactly whether there is a bladder issue or there is a prostate issue, and accordingly we'll be able to give medications to specifically tackle those so that this patient is able to empty his bladder properly without resorting to clean intermittent catheterization. Of course, this would have to be followed up to make sure कि urine ठीक से खाली हो रही है या नहीं. And with these medications, if he's able to pass urine well, and there is not much of a residue left in the bladder, then yes, we may not always require clean intermittent catheterization.
So especially in a male patient, which was the message that I wanted loud and clear, because एक chat box में comment आई थी कि मैं ये दवा ले रहा हूँ. So especially for MS patients, if you are a male, if you are in the age group where prostatic enlargement normally impacts men, just because you have MS doesn't mean other diseases will not catch you. तो MS के साथ बाकी सारी तकलीफें भी जरूर हो सकती है, और अगर वो प्रोस्टेट वाली बीमारी है तो your doctor will guide you. And the same medications which are used in otherwise normal men for enlarged prostate will also help MS patients. So as Shruti has already taken the name, silodosin or tamsulosin are the most commonly used medications. And the way we use them is no different from the way we would use them in a male patient without MS. So don't think that just because you have MS, मुझे prostate वाली problem है या नहीं, कैसे करूँ, क्या करूँ. There is a solution for everything. Shruti, one more question to you. So I am 40, I have MS, I do need a diaper, I am on medication, but now there is an added problem. मुझे बार बार infection हो रहा है. बुखार तो नहीं आता है, but anytime I check my urine, it shows 50 to 80 pus cells. I don't really know how to deal with that. So could you give me some very simple advice कि MS के पेशेंट है जो डायपर में है, जिन्हें UTI हो रही है, what would be your advice? What are the commonly used medications? My doctor says you have to stay on a medication long term. Is it safe? I'm so worried it's an antibiotic. So what would be your advice to me, Shruti?
So in any patient जिनको कोई यूरिन की incontinence हो या यूरिन ज्यादा बच रहा हो, a urine tract is like our the flush system of our house. If the जो urine है वो पूरा ठीक से निकलता नहीं है, then it might lead to some infection. There are few different types of infection that can happen. One is called asymptomatic bacteriuria in medical. That means that there is some pus cells in the urine, but patient को कोई symptom नहीं है. What are the common symptoms seen in UTI? पेशाब में जलन होना, there will be some burning, पेशाब बार बार जाना, urgency, or you have to go again and again, and it may even leak. If the infection gets worse, then it may cause some infection on the kidneys, although that is very rare. If we feel that this infection is causing a problem in the bladder or in the kidneys, then we will keep these patients on long-term antibiotic prophylaxis. ये long-term antibiotic prophylaxis में commonly used drug है nitrofurantoin. ये एक बहुत कम डोज में हम लंबे समय तक देते हैं, so that it decreases the infection and decreases the pus cells in the urine and prevents these symptoms from developing. This is a very safe antibiotic. It goes in your mouth, it goes in your stomach, and it directly comes out of the kidney and goes inside the urine and acts only in the urine area. It usually does not give any side effects elsewhere. So there is no problem in taking it long term. It is also given in small children who have MS. Another thing which I would like to add is, जैसे अगर कुछ patient self catheterization पे है, they are putting catheter on their own regularly, उनमें अगर हम यूरिन टेस्ट करें और यूरिन में कुछ 10 पस सेल 20 पस सेल आए, then it may not be necessary to treat these patients as UTI, क्योंकि this is again a asymptomatic bacteria which is due to a catheter, and it does not mean कि patient को UTI है. So a symptomatic patient with UTI, we will definitely give long-term antibiotic prophylaxis, but not unless the patient is having some symptoms. Not unnecessary.
That was something very important. And not only that, if there is an MS patient जो कि wheelchair bound हो, या they are largely immobile, are having to use a diaper, in fact, a lot of pus cells in their urine could be due to contamination. And especially if it's a female patient who's a little bulky. So just a urine report showing pus cells does not mean you've got UTI. But we need to sometimes collect the sample by inserting a catheter so that contamination nahi hai. And if that sample also shows infection, then we have to individually customize whether this infection is worth putting the patient on antibiotic, and that calculated decision the treating urologist will take. Patients should never self-medicate with antibiotics. Don't say that another patient with MS had UTI and she responded to this, so should I start this antibiotic, or I will start the antibiotic on my own? Please don't do that. Antibiotics are not meant to be started. There is nothing like a free meal. Don't do something which has got a potential to give a side effect. So even simple paracetamol can have side effects. So antibiotics should only be started if your doctor advises them. Don't treat a report. Let your doctor advise what is the correct antibiotic for you. I'm switching over to Sanjay. So Sanjay, I have been on medication now. I have been taking solifenacin, and I am 55-year-old, and my MS is really gone for a toss right now, and I'm miserable. I'm miserable because there is a lot of leakage. And somebody has suggested that maybe I could take Botox, and I have no idea what Botox is all about. Do I take Botox in the bladder? Do I take it in the muscle controlling the urine? Who decides, and who do I go to? I'm totally lost. So could you guide me whether I'm the right candidate for Botox? Give me some insight on that. Sanjay, over to you.
Wonderful. So I'm 55. I have got issues with MS, where MS is a progressive waxing waning disease, and my lower urinary tract is in trouble right now. The urologist would decide what do we do, and even with solifenacin, which was good enough in that era, where we escalated dose, as Dr. Shruti said, from 5 to 10 milligrams, I'm not good enough, which means that the progression of neurological issue is bringing about urological issues, which is worsening. I need a quality of life, which means that botulinum toxin or Botox is a medication right now available, which we use for various specialties in the world. In urological specialty, it is used in the bladder and the urinary sphincter. In the urinary bladder, the bladder which has now become completely insane and is not responding to the full dose medication that we were giving with safety of no side effects. Now we want to look at a localized therapy. Remember, all this time, doctors or urologists were giving you medication from the mouth, which would bring about various effects that were desired, and sadly, some undesirable effects which we could counter by counseling and taking forward, and we were leading a good quality of life. As MS progressed and worsened with exacerbation, it is not working so well. My job, therefore, is as a urologist to help out a patient who did very well and suddenly has worsened as a result of this change. Botulinum toxin or Botox is an injectable therapy which is injected in two locations for two different kind of issues. Now remember, this overactive bladder is contracting erratically. ये शैतान बच्चे की तरह बार-बार हमारी बात अब मान ही रहा. अब इसको शांत करने की जरूरत है. Which means that Botox is given by a cystoscope. ऑपरेशन टेबल पे दूरबीन के रास्ते हम जब अंदर जाते हैं तो पेशाब की नली के थ्रू जाते हुए ब्लैडर में पहुंचते हैं. ब्लैडर विच हैज अ कैपेसिटी नॉर्मली ऑफ एनीथिंग बिटवीन 350 ml to 500 ml is not letting you hold urine even 50, 20, 100 ml compared to what it was. So the plan here is to inject botulinum toxin or Botox into the bladder wall so that the bladder contraction slows down. So injection in the bladder, as Dr. Anita said, of the dosages as required is given so that ये आप हर दिन दवाई खा रहे हैं और दवाई यहां से जाके ब्लैडर में काम करती है और वो काम नहीं कर रही है, इससे अच्छा होगा इस स्टेट में जहां हमारी एमएस ने हमारी ब्लैडर को बहुत तंग कर रखा हुआ है, दैट वी गिव द मेडिकेशन इनटू द ब्लैडर डायरेक्टली इनटू द एंड ऑर्गन. और जब वहां लगाते हैं तो इसका फायदा ये है कि हम उसे इंजेक्शन के रूट से देते हैं. ये कहीं 15 से 25 मिनट का काम ऑपरेशन टेबल पे होता है, जहां दूरबीन के रास्ते आपके यूरोलॉजिस्ट एक 100 यूनिट्स या 200 यूनिट्स, डिपेंड करता है किस तरह की डोज रिक्वायरमेंट है, ब्लैडर में वो इंजेक्शन देते हैं, जो ब्लैडर को पूरी मैप करके अलग अलग जगहों में लगाई जाती है. इसके बाद इसकी इफेक्ट कहीं 10 दिन 2 हफ्ते में शुरू हो जाती है और आपको अच्छा लगता है. आपको वो मुश्किल जो सोलिफेनासिन के पहले जमाने में था, जिसमें कोई कंट्रोल नहीं थी, सोलिफेनासिन से फायदा हुआ था, इट गेट्स बैक टू close to normalcy gradually, which means we injected into the bladder for a refractory overactive bladder, which is not being controlled by my medical management with dosages escalated to safety levels. Now, this was in the bladder. Now, the good thing about this is this actually is effective for anything between 4 months to 6 months to even 9 months. Patients whom we have injected have even done well for 9 to 12 months of MS patients and other neurological patients. तो इसकी डोजेज नॉर्मली न्यूरोलॉजिकल पेशेंट में 200 यूनिट रही है और इडियोपैथिक ओवरएक्टिव ब्लैडर में 100 यूनिट रही है, पर वो आपके डॉक्टर डिसाइड करते हैं. तो फायदा क्या हुआ? आप ये हर दिन दवाई खा रहे हैं, आपको फायदा नहीं मिल रहा है कंपेयर टू वन प्रॉपर इंजेक्शन इनटू द ब्लैडर व्हिच ब्रिंग्स अबाउट अ टेम्पररी कीमो डिनर्वेशन ऑफ द ब्लैडर, ताकि टेम्पररीली वो अगले 3, 6, 9, 12 महीने तक आपको उस तरह से रखे जहां हर दिन की दवाई की जरूरत नहीं है, क्वालिटी ऑफ लाइफ अच्छी है, आपके डॉक्टर फॉलो करेंगे दैट द रेसिडुअल वॉल्यूम्स आर नॉट गेटिंग हाई एंड यू नॉट गेटिंग एन इन्फेक्शन. तो ये रहा ओवर एक्टिव ब्लैडर. But Dr. Anita ने ये भी बताया that my MS has worsened. When MS worsens, it can also bring about a situation which is called as detrusor sphincter dyssynergia. मैं चलता हूं, दरवाजा खुलता है, मैं बाहर पहुंच जाता हूं, ब्लैडर कॉन्ट्रैक्शन करती है, रास्ता खुलता है, यूरिन निकल जाता है. अगर ब्लैडर ने कॉन्ट्रैक्शन किया और रास्ता नहीं खुला तो पेशाब नहीं आएगा. तो वो सिनर्जी जो थी ब्लैडर और एग्जिट में, वो गड़बड़ है. तो ये स्फिंक्टर जो एक्सेसिवली कॉन्ट्रैक्शन कर रहा है, इसको हम शांत कर सकते हैं कि ये कॉन्ट्रैक्ट ना करे. हम सबका स्फिंक्टर खुलता है जब ब्लैडर कॉन्ट्रैक्शन करती है और यूरिन निकलता है. स्फिंक्टर यूरिन कंट्रोल के लिए बना हुआ है. अब अगर ये स्फिंक्ट्रिक मसल बहुत हाई टोन में है और हमारी यूरोडायनेमिक्स में, हमारी अंडरस्टैंडिंग में डेट्रूजर स्फिंक्टर डिसएनर्जिया की मुश्किल हो रही है, जिसमें पेशाब खाली नहीं हो रहा है, जोर से पेशाब लगा गए और जोर लगाए तो कुछ खाली नहीं हो रहा, ड्रॉप ड्रॉप आ रहा है, जबकि ये पहले नहीं था. सो दिस इज एन इफेक्ट ऑफ एमएस ऑन टू वेरियस एस्पेक्ट्स ऑफ द लोअर यूरिनरी ट्रैक्ट. देन योर यूरोलॉजिस्ट विल इंजेक्ट the Botox into the sphincteric skeletal muscle, which will slow down the overactivity of the skeletal muscle जो urinary passage को control करता है. As a result of which, the sphincter will not be overactive or dysenergic to the bladder contractions and your urine flow will get better. The interest is आपकी पेशाब वही बैलेंस में आ जाए जिसमें ब्लैडर कॉन्ट्रैक्ट करे, रास्ता खुले और पूरा यूरिन निकले। तो क्योंकि दवाइयां काम नहीं आ रही, बोटॉक्स इज अ ग्रेट थेरेपी। इट्स अ थेरेपी फॉर रिफ्रैक्टरी ओवर एक्टिव ब्लैडर, फॉर रिफ्रैक्टरी डिसएनर्जिया विच कैन नॉट बी मैनेज मेडिकली। लोकली जाके वहां ट्रीटमेंट करें, और ये ट्रीटमेंट लॉन्ग लास्टिंग है। ये ट्रीटमेंट को रिपीट करना पड़ता है, कभी 6 महीने बाद, कभी 9 महीने बाद, डिपेंड करता है आपके ऊपर। तो इस तरह से आप ये दवाइयों से वंचित रहते हैं, आपकी थेरेपी हो चुकी है, आप अपने रिजल्ट्स पे हैं, एंड वी टेक इट फॉरवर्ड एज रिक्वायर्ड इंडिविजुअली।
Lovely. So, Sanjay, I took Botox 2 years ago and then I was fine and MS was quiet for about a year. Now my symptoms have come back and I think I need to have a Botox shot again. Can I take it again? Will it work as effectively and will
Yes.
there be more side effects?
Wonderful. So Botox is a wonderful drug. It is all about working, lasting, but still temporary effect till a point in time. It's not forever. So if the effect went away after 6 months, 1 year, but my MS also came down, I was good enough. My MS came back, and it came back quite dramatically. In other words, I've got quite significant symptoms. I know my bothersomeness. I know that solifenacin will not affect. Botox is an answer. So we can give Botox repeatedly into the bladder. There are patients who have taken yearly or semi-annually Botox and have done very well in their quality of life. वो हर दिन दवाई खा के फिर भी रिजल्ट ना आए, फिर भी डायपर पहनने की जरूरत नहीं पड़ती। So it's again patient to patient kind of thing.
Lovely. So I'm going to be asking one last question to Shruti and then hand over to Mike to Dr. Rekha in case she has any specific questions to ask us. Shruti, one final advice from you. So one of your MS patients is now 31 and she's on intermittent catheterization and she's doing well, but she's just discovered she's pregnant. And of course, she's going to have to continue the self-catheterization and she's extremely worried. So what would be your advice to a lady who is dependent on self-catheterization and is worried she's already pregnant? So give her some insight about intermittent cath during pregnancy.
Yes, ma'am. So, patients who have MS or for that matter, any urinary problem or who are on self-catheterization, or these are patients at a higher risk of urinary tract infection. They might likely develop urinary tract infection. This becomes a slight problem once the patient gets pregnant because any symptomatic urinary tract infection, in the symptoms and it might be bad, it can lead to problems in your pregnancy. It can lead to preterm abortions. It can cause some problems in pregnancy. That is why when a patient with MS on intermittent catheterization gets pregnant, it's very important to periodically check this patient for if she's having any symptoms of UTI, if she's having a urine culture is growing anything. This patient may or may not require some antibiotic if the treating urologist or gynecologist feels that this urinary tract infection is causing problems for the patient. Also, another thing that happens is regularly in a patient who is pregnant, especially जब पेट बहुत बड़ा हो जाता है, baby और बड़ा होता है, that time it may press on the ureters like you showed in your slide, ma'am. There are the ureters, the pipes that come from the kidney. It may press on those pipes and cause some slight swelling in the kidney. This may not be related at all to MS. This naturally happens. So it can be a little confusing to understand in pregnant patients कि ये urine infection kidneys में असर हो रहा है या नहीं. It's very important to just remember that you have to continue proper clean intermittent catheterization using all sterile precautions. Preferably don't reuse the catheter. Keep that area clean, use your gloves, and just continue the same as you were doing before. Go regularly for your checkups, for your urine tests, for your ultrasounds to make sure you are emptying properly. Like Sanjay sir mentioned, the two most important times to empty is the first thing in the morning and before sleeping at night. Make sure the bladder is completely empty. As and when the baby starts growing, it presses on the bladder, so you might start getting that sensation of full bladder much earlier than you used to do before. You might have to increase the number of times that you are putting the catheter. So these are the basic things that my take-home message is a lady with MS can have an uneventful pregnancy, and there is no problem in that at all. So don't think that just because I have MS, I do not, I may not get pregnant or this might be a problem. It is not true. It's just that you do need a little bit more of a follow-up and more checkup than a normal lady with who has been pregnant.
Lovely. And in fact, this may be the only group where we as urologists might advocate using a new catheter each time, just so that possibility of external infection is minimized at least, and make sure that you are periodically following up with the correct specialist. So before I hand over to Dr. Bhatkhande, thank you so much, Shruti and Sanjay. I want to tell everybody who's online that neither Sanjay nor Shruti had any clue about what questions I'm going to ask them. And in fact, they have answered them exactly how a patient would suddenly ask them in the OPD. And that is how they have dealt with the question. So I'm so happy because this was the format that I wanted. Otherwise, somebody comes all rehearsed with a presentation, then that somebody knows exactly what he or she is going to talk about. So first of all, this was wonderful, both Shruti and Sanjay, and I expected only that from both of you. So thank you so much. Before I switch over to Dr. Rekha, any comment from Shruti first and then Sanjay?
So just in the end, I'd like to thank Anita ma'am and Sanjay sir for being here. I learned so much, and I'm sure the patients also have learned so much. It's really a privilege for them to learn from you. And this is a very good activity which should be done more regularly, because MS is a chronic disease, and to find people who are from the same, who are suffering from the same disease, to have a platform where these patients can speak openly, that is very valuable.
Thank you so much. Over to you, Sanjay.
Great. So thank you and congratulations both to MSSI, to Dr. Anita for having thought structured and brought it in a very crisp kind of a issue. I know we cannot teach things in such a short time, but it's all about awareness and awakening. And that's what has been brought about by this platform. Dr. Anita leads the March of Female and Functional Urology in 2025. Mantle from January till April, where we are going to celebrate this by looking at caregivers helping us out across the country with the Female and Functional Urology Society is meeting, which we do as focused as you see today in this session. We run 2 days session around. So I salute you, Dr. Anita, for the way you march it across the country for us colleagues and for all students and general public in advance. Finally, friends, age-related changes will not go away. They will happen. None of us are statues of Mahatma Gandhi which get polished by the rainfall. The statues looks like that all the time. Our bodies are undergoing a change. मेरे काले बाल सफेद होते जा रहे हैं, मैं 50 से 55 होता जा रहा हूं. Body will change and we are powerful people. We are powerful enough to talk about it, talk to the right doctors, reach the doctors in time in your locations, and that is all we seek from this platform, which is all about bringing positives in sadly disease processes. Friends, you do your best and God will do the rest is all that we follow. But in today's seminar, it was you do your best and your urologist will do the rest. So see your urologist for your urinary complaints, for your sexual complaints. Please complain, and complaints are there to answer. We follow a Hippocratic oath where we look at your quality of life continues to stay very good in those quality of life diseases which we talked about. Antibiotics are given both for cure as well as for prophylaxis. And that's what Dr. Anita and Shruti were talking. Prevention of UTI by low dose antibiotics and treatment of UTI by full dose antibiotic. So there's so much which is missing in public domain. And I'm feeling so proud and so self-immersed on a Saturday morning on a kickstart of January, the first month. Thank you so much for giving us an opportunity and taking it forward with very powerful positive signals for the society.
Thank you, Sanjay. Thank you, Shruti. Thank you, MSSI. Over to you, Dr. Rekha.
Anita, thank you very much for an excellent session on urological problems in MS. You know, one thing you had said that squatting is probably the best way for a female to empty her bladder. Now, I'm a gastroenterologist. So what we have done is that we realized that sitting on in what they call as a Western, on a commode, is not actually the ideal way. And we have actually asked our patients, constipated patients, to have a stool underneath their legs so that the legs are in a jackknife position. I think maybe this would also probably help in urination. I mean, that is something that, you know, perhaps you could do urodynamic studies to see whether the flow is better and things like that.
Sure.
Dr. Sanjay, thank you so much. Botox is there, has come. The only question is it's quite an expensive therapy. So, you know, that is also to be factored in when we talk about newer therapies in our MS patients. And of course, we have, it's been really wonderful having all of you here. And of course, where Shruti is concerned, Shruti, it's all about quality of life, and you've told us about medicines. But there are a few things about diet as well that we need to look into. And one of the usual things that are told to MS patients is cut out your caffeine. So does it really matter? When you have a bladder dyssynergia or you have problems, does caffeine really matter? Because I'll tell you, in constipation, it does. So how does caffeine affect, your urinary dysfunction?
Caffeine can definitely, one is it increases the urine production, it's a diuretic. Second is it can worsen the overactive bladder. It can lead to the bladder contracting more. But of course, this caffeine, when I'm talking about, is excess caffeine. Having 2 cups of coffee a day is not going to cause problems to you. If you go excessively, have 4, 5, 9 cups of coffee a day, then it will worsen the symptoms of overactive bladder. It will lead to increased urine production. It will lead to a frequent urination, getting up more often at night. So these definitely caffeine, even excess of tea, this will cause these problems.
Yeah, thank you so much. I think we have Dr. Varsha Patil, our neurologist, is already on the scene. So I think I'll wind this up saying that it has been an excellent session. My MSPs have really learned a lot. And all my, in the group, in the chat, I can see a lot of clapping and, thanking the speakers. So but we're not going to let Dr. Sanjay and Dr. Shruti, we're not going to let you go like that, okay? We are going to have you involved in the MSSI future meets and also, trouble you for advice, because this is something that we really need to connect with our specialists to get the best for our MSPs. Thank you so much.
Thank you, ma'am.
Thank you so much. We'll take your leave.
Thank you, Anita. Thank you, Sanjay. Thank you,
Thank
Shruti.
you.
And I wish both Sanjay and Shruti are with us now forever, like
Thank
you are always forever.
Thank you so much.
Dr.
Sorry,
Anita
ma'am,
leads.
sure.
Dr. Anita leads the pack all the time, please. Yeah.
Not
Thank
really.
you.
Thank you. Have a good weekend, everybody. Thank you to every
Thank
member
you
of
so much.
MSSI. Thank you so much.
Thank you.
Bye-bye. Bye.
Bye. Thank you. Thank you.
Javed?
Thank you.
Javed? Yeah, thank you so much. So I think we'll go straight into the next session. Dr. Varsha, welcome to our session this morning, or rather noon, I would say. And we all know you, but yet I have this proud privilege to present you here today. And Dr. Varsha Patil is a very well-known neurologist. She practices she's a consultant neurologist at Bombay Hospital. And she has always guided Multiple Sclerosis Society of India. Her actually area of interest is autoimmune neurology, and multiple sclerosis is very much up her street. And so, Varsha, I would request you to kindly take over. Please present your insights on your topic to us, MSPs. We're all waiting, eagerly waiting, I would say.
Yeah. Good afternoon, everyone, and thank you, madam, for a very kind introduction. Without much ado, I will like to share my slides. So I was told by Chitnis madam that we definitely want you to talk on the newer drugs, and obviously the most important question that faces our patients with MS, that is pregnancy and what implications would pregnancy have in MS. So I've probably, going to give some importance to the therapies and then talk on the pregnancies and its relation to MS. Are my slides visible?
Yes.
Yeah, just a minute. I'll just put it on the slide share mode.
Yes, ma'am.
Apologies, a little technical hitch. Let me just see where I can. Probably I'll just share it again. So there are two aspects to treating multiple sclerosis. And so the first and the most important aspect here is why treat multiple sclerosis and what are the options that we have in multiple sclerosis treatment. Now, when we are going to talk about it, I'm going to talk about a lot of share. I'm sorry. Somehow it's not going in the presentation mode. Let me just put it up
Do you
first
want
in
me
the
to share your
presentation.
presentation? I can share.
Let me just try this once. If that's done, then we don't need to. Yeah. Yeah. Is it visible now?
Yes,
Yes.
Yeah.
it is.
All right.
Thank
And am I audible and clear?
Yes.
Absolutely.
Yeah. Yeah. So very good afternoon, everybody. And after the exciting talk on the most important, probably the most practical aspect that affects the urinary tract and MS, I'm going to talk now a little more on therapies, a more focus on the newer therapies, and then the burning question of pregnancy in MS. So just a brief overview. It's probably a repetition. Every one of you all knows it, but I want to start it off with that. So basically, MS is an autoimmune inflammatory demyelinating disorder of the central nervous system. It's well known in MS since probably the first descriptions which were given by Chapeau. And so the frequency that is quoted in the US and probably the European population is somewhere close to 90 to 150 per 1 million. But in India, if we look at the statistics, it says 7 to 10. But this is, again, a little biased and a little underestimated values, because there is now a greater awareness among neurologists, radiologists, and physicians. And I would say the incidence and the prevalence is much higher than probably this number that was quoted in the paper in 2015. So what is MS and what are the symptoms and the types of MS? So basically, MS results because there is a damage to the protective coating that is seen over the nerves, that's called as the myelin. And here we can see in this picture beautifully, there are these structures. So this yellow structure is a nerve, and then it has, fascicles, and each fascicle has a coating. So within the nerve also there are some blood vessels, but when we are really looking at damage, we are looking at damage to this yellow part that is described in the cartoon. And when we look at this picture, this is a more detailed picture of the smallest part of this nerve, that is the neuron. And if we can see this, the coating that is there on this connection of the neuron, this is the myelin sheath or the axon. So this is exactly where your antibodies in MS go and damage and produce the symptoms. So when we classify MS into clinical phenotypes, we look at what is the attacks and whether there are continuous, relapsing remitting. So attacks come and go, or whether it's a progressive course of the disease. So when we have just one in episode, then it is a clinically isolated syndrome. But when there are, say, attacks, so attack treatment, remission, then another attack. So this is the relapsing remitting MS, which is the commonest form of MS. Your 80 to 90% of patients are going to be RRMS. And that is actually very important when you look at your therapeutic strategies. Then the second group broadly is your progressive MS. So that means that at one point of time, the disability just continues without any attacks in between. And there is this, the rarest form, that is your PPMS, where from the beginning, you wouldn't have an attack, but there would be a continuous accrual of the disability. That is the PPMS. So the symptoms of MS will depend on which part of the nervous system is affected. If it's the eye, then you can get the optic neuritis and vision loss or vision blurring. If it's the brainstem, you may get a little bit of ataxia or symptoms of vertigo or double vision. If it's, the arms or the legs, then you get the weakness. If it's a pains that we can get, your trigeminal neuralgias, your neuralgic pains in the spinal cord functions, and sensory loss. But other than this, there are very important symptoms, what we call is probably the hidden symptoms that bother patients with MS the most. Your sexual dysfunction, cognitive dysfunction, mind fog, as they call, a lot of fatigue. So fatigue is experienced by almost all our patients that come to the clinic. So then how do we treat MS? So when I'm putting MS in the middle of this block, there are 4 prongs that I look at treating. So you have your disease modifying therapies, that is your DMTs. You will keep, hearing from your doctor about the term DMT. Then second is the symptom management. So obviously we give the DMTs for a particular purpose. But when you come with a particular symptom, there will be another set of drugs that's given. And most important, other than these, is obviously healthy lifestyle choices, which we always emphasize to our patients, and managing the comorbidities. This is more for a little older patients who may have other illnesses other than the MS. But, largely our group which comes to MS are the young population. Now, so what are the goals of a treatment when you go to your doctor? So the doctor would think of treating you on these lines. You need to minimize the relapses. Then when you're looking at the imaging, because there will be a serial imaging that is advised for, that is mainly to minimize the new lesions in the MRI, because this is where the damage starts happening. If you start getting new lesions, you get new active lesions, you know that the disease is very active. Then the most important is to delay or prevent your progressive stage, promote better aging, and improve the overall quality of life. So when we look at treatment goals, we look at acute therapies and chronic therapies or the maintenance therapies. And we all know that for the acute, usually if the first most is IV steroids, that's corticosteroids. If the attack is more severe, then you may be also offered plasma exchange or IVIG, and obviously physical therapy. And for prevention of the attacks, we have this set of groups, that is the disease modifying therapies, which is going to be the focus of my talk. Now, so when should the DMT be started for MS? So often, in the clinic, when we have this discussion with the patients, when we start the therapy, so if I get a patient with MS in the clinic, the first and foremost thing is to educate the patient about their diagnosis. So there are a lot of these questions that come up. So doctor, how did I get MS? What could have gone wrong that I got MS? And do you really think this is going to progress? Or do you really think I need to take therapy now? So, there are those who have, probably some subtle symptoms which get completely okay with their steroids. And there are those group of patients who will be a little anxious in this, why should I take a pill or an injection for a long time? And can't I just wait and just take multivitamins and see what happens? And if I get an attack, doctor, you give me the steroids. So there are different types. So as the fingers of the hands are not the same. Everybody has a different mindset. But if you look at the international standards, and if you look at the Indian consensus guidelines, there is a very important note that everybody makes in the recommendations. Start treatment quickly at a young age for better clinical outcome. So if you go to the American or the European standards, they would say that even if it is a clinically isolated syndrome, which means I saw the first attack and the parameters don't tell me that this could be MS or that may not be MS. They are still quite sure that you need to start you on your disease modifying therapies, because in the long run, we have to look at three things. We have to look at disability limitation, prevention of relapses, and ultimately a good quality of life. So that's first answer. Then the second thing is, if I have to start the DMTs, which DMTs do I start? So again, this is the second part, probably second part of the interview that happens. So the patient is giving the full information, the relatives are given the full information about what type of DMTs are available. So when you look at roughly DMTs with multiple sclerosis, you could have those which are injectable ones and which are orals. So maybe, 50 years back, if we had to look at somebody who was diagnosed with MS, unfortunately, we had nothing more than your interferons, or maybe earlier than that, because we keep seeing those follow-up patients. A lot of you may relate with that, where there were people who were given just monthly steroids or monthly ACTs injections, and nothing more could be offered. But now, with the progress over the last few decades, we know that there are many drugs available, and then I will be talking on a particular group, that is your highly effective therapies. So the injectables, the first line therapies as we call them, are your interferons and your glatiramer acetate. So these are immunomodulatory, so they don't suppress your immunity. So there is a less risk for what is this progressive multifocal leukoencephalopathy. A lot of you, if you Google, you will, there will be the first thing, the risks involved with DMTs, and that's probably the biggest worry that patients have. There is a lot of experience on using these drugs, and they have minimal safety issues. And probably this is one of the safest DMTs for pregnancy. And I will talk about it when I'm talking about the pregnancy bit. So the next group is your oral DMTs. So the oral DMTs, there are, if I look at the Indian, pharmacological drugs that are available, we have your dimethyl fumarate, the teriflunomide, which is quite easily available both in the generic forms and in the original forms, and the fingolimod. We still don't have the siponimod and the cladribine. So these are convenient because you are not needing any needles. The efficacy is as good as the injectables. So if I had to probably give you a snapshot of what therapies are just now available for the treatment of different types of MS, we have your first line injectables, first line orals. Then you have this group of highly effective therapies. So I spoke about this, the left side of the picture. Now the highly effective therapies would be your natalizumab, your fingolimod, and the group that is anti-CD20 molecules, which is probably now being very commonly used by neurologists, even for an advanced, probably for a case which is escalated. I will tell you what escalation means, and even treatment knives. So as even been offered as the first line therapy with the diagnosis of MS. And obviously we have more stronger drugs, which are called as induction therapies, which means you are going to suppress your immunity completely so that the anti-inflammatory cascade is completely down. That is your alemtuzumab and cladribine. But of course, they are very strong drugs. So there are particular indications when you would start somebody on alemtuzumab or cladribine. I wouldn't be talking much in details about these two. So going on to the monoclonal antibodies. So we have these anti-CD20 monoclonal antibodies. So why is this term anti-CD20? Basically, when you look at anybody's immune system, so the immune system, from the medical knowledge, if I have to tell you simply, these are the soldiers of the body which try to help the body in trying to control any attack on the body. So who would be attacking the body? It could be the bacteria, virus, fungus. So when we have to kill them, there are something called as antibodies. So these antibodies can be the B cells or the T cells. So the B cells are the ones which produce the antibodies. Okay. And the T cells go and directly attack. So when we talk about MS happening to someone, there is an aberration in your B cells and T cells, and that is why the immune system gets rewired and it doesn't understand that you did not attack your own body cells, your myelin sheath, your neurons. And so when they start attacking the immune system, the damage to MS, that's the demyelination happens. So within these B cells, okay, the B cells of the immune system, there are certain markers that are there. So you will be, hearing about your doctor about CD20 and CD19 levels. So this CD20 is the important marker because at that stage, the B cell is ready to produce antibodies. So what I'm going to do is, if I have a B cell, which is a very bad B cell, why I'm saying bad B cell? Because this B cell is producing an antibody that is going and attacking my immune system. So how can I counteract this B cell? What I will do is I will give a molecule through the IV or as a subcutaneous injection, which can go and destroy the CD20 epitope on the B cell. Epitope, I mean to say a particle on that B cell, so that that damaging or that harmful B cell is destroyed. Now, so if I'm going to destroy the origin of these bad antibodies, naturally, the patient will have a less tendency to have relapses. Okay. And there will be also theoretically a chance of healing from within. So when we give somebody the therapy, unfortunately, just now we don't have therapies which can repair your, myelin or remyelinate, but it can definitely try to aid in the repair of the neurons. So I don't have a cure for MS just now, but I have drugs which are as good, which can probably stop the relapses and which can also help in a little bit of, repair of those nerves. So that's why these anti-CD20 molecules have become a little more popular. That's what I want to tell you. Now, when we look at this, the block in the center, we have the natalizumab, we have the alemtuzumab, and the anti-CD20. I have highlighted the anti-CD20 because the latest WHO essential drug list that was out has notified rituximab as one of the essential drugs which is available for MS. Now, you can also see that I have tried to segregate these two top molecules from the three down molecules. That's because the top ones are really stronger ones. So not everybody with MS is going to be offered an natalizumab and an alemtuzumab. It is usually when you fail your, second line, or the drug is, or the disease is extremely aggressive, what we call as highly active MS. In those situations, we may offer a patient natalizumab or alemtuzumab. But again, the stronger the drug, the stronger the side effects. So every drug, every drug that is going to suppress your immunity is going to make you prone to some sort of infections, some sort of harmful side effects. So if we consider this, the highly active group, this anti-CD20 somehow has a little more better safety profile than your natalizumab or alemtuzumab. And so these are immunosuppressives. They do have some high risks. They are high efficacy. And they're available not as orals, but as injectables. So it could be either through an IV drip or through a subcutaneous injection like your insulin. So what are the indications? So though the WHO does put it in the essential drug list, if you look at the indications for the Federal Drug Bureau, rituximab is still not approved for MS, but it has been used for a very long time in the Swedish, Danish, and the Indian population. And it is mainly for all types of MS. So your RRMS, SPMS, and PPMS. And the FDA approves these two molecules, the ocrelizumab and the ofatumumab. So ocrelizumab is approved for both, again for the progressive and the relapsing forms, and ofatumumab also for both. Now, the only difference between the ocrelizumab and rituximab versus ofatumumab is the way we give the injection. So rituximab and ocrelizumab are IV, and the ofatumumab is usually a subcutaneous injection. And the frequency with which you give the injection also differs depending on the molecule. So this is just to show you that there have been studies. Our group, under the guidance of Dr. Singhal, has also done and tried to see how safe and effective the rituximab is for MS and other central demyelinating disorders. And I would say that it is quite safe and effective. So if I go back again to these B-cell targeted therapies, they are highly effective, they are well tolerated, and they are usually a first or second line in moderate to severe MS. The only catch that we need to remember is if you're giving it for a long term, there will be some risk of infections, and the long-term safety data is still evolving. So going back to the therapy approaches, which any neurologist or any patient will face when the first question is which drug do I start, and do I start the most effective and the most strongest drug, or I start with what is called as the first line. So not all. So the first disclaimer in this is that not everybody is going to require a highly effective therapy at the start of the disease. There are a lot of factors. It cannot be a mathematical calculation, because when we deal with patients in the clinical practice, it is usually a sum of different parameters. So it is going to depend on what is the patient profile, what is the age of the patient, what is the clinical attack that the patient has for the first time, how severe is the attack when he or she had it for the first time, and then whether there are markers to say that this patient may have a tendency to have repetitive attacks, or the other question that comes is this patient going to be soon going into a progressive phase? And then we look at the comorbidities. That means, are there any other illnesses in the patient which can interact, which can be harmed when I am starting the patient on therapy? Then the next important question comes is, if this is a young lady, is she going to get married? Is she going to plan a family soon? And where do I place my therapies? The last would be obviously that, the choice of the patient, because in this whole circle of discussion, the patient comes at the center. So the patient has full right to be educated about what are the different options available, what are the risks and pros and cons of the therapy, and then obviously it will be a choice between the patient and the treating physician. The family also plays an important role, but ultimately it has to be a two-way discussion. Then obviously it's not that when you're offered, you can probably just you have no option but to start. You can take your time, right? Second thing is, there are so many times when we may think that a particular drug works for a patient, and we may be right, or the patient may have a relapse even after starting, say, dimethyl fumarate or teriflunomide or interferons. So then if I'm giving drug A and the patient has clinically had recurrent relapses, or you feel that the disability is going down, then I'm going to, instead of drug A, give a drug which is stronger than drug A, that's drug B. Okay, this is what is the pyramid on your left-hand side. So if the drug B, after starting the drug B, again, the patient probably has markers to say that there is progression, I have an option of going into drug C, and probably then at the top of the pyramid, that is your highly effective therapies. So one group of neurologists or physicians would go with the escalation therapy. That means we are going higher up in the pyramid. Now, again, there is no hard and fast rule. I will re-emphasize that there are many factors playing into a decision-making process, and there can be no clear answer. So if a patient probably has had a mild optic neuritis, she's a young lady, she's probably going to, get married soon, and she is, going to plan a pregnancy soon, I'm not justified in starting her on a highly effective therapy just because there is a belief that the highly effective therapy may just crash down all the, relapses, because obviously no drug is foolproof. So here in this case, I would rather start on something which is a milder form, which is probably safe when we are going to consider her going into the reproductive age, and then look at how her journey of MS goes. Here, I wouldn't, simply say, come on, now we need to, you have MS and I'm going to start you on this drug, and this drug is extremely effective and you will absolutely get no relapses with that. So that's one. So in this case, I'm not going to go on what is called as an induction therapy. Then what is induction therapy? I'll give another example. So this is a young boy, he's 17. His first ever attack, he has a double vision, he can't walk well, he can't stand well. The brain MRI shows multiple lesions which are enhancing in the brain, in the brainstem, in the spinal cord. There are some optic nerve signals. I've given him 5 days of steroids, and this young chap is still quite disabled. So it is a very severe attack. Then look at the second risk factor, male, young male, then having a brainstem attack. So these are some pointers which we say are poor prognostic factors, which means this particular patient may have a tendency to have a progressive disease and probably may land up with disability later. So for this chap, now since my steroids are not working, I will think of rather giving him plasma exchange or an IVIG because I want to get him out of the attack. Then the second question would be, then do I start him on just injectables or tablets, or do I consider something else? So this could be a clear-cut scenario where in the first place, even after the first attack, I would say, look, young boy, we need to think about treating your disease into complete control before we think of milder drugs for you. So here I would probably offer him a highly effective therapy. So this is called as induction, which means that there is a clinical indication and I need to get the disease inflammatory activity completely under check. So I would go for the highest drug first, keep him into what we call as clinical and radiological remission, and then once he's a little stabilized, probably go down on his therapies. Okay, so then there is a lot of debate, and so the question again comes is, when you look at a bigger picture, will your escalation help or your early intensive use of disease modifying therapy help? So they tried to look in the real world. So there was the Danish cohort and the cohort from the other country. So what we can see here is that this group, okay, so accumulation of disability, that means 0 is that some person has never had any disability because of MS and has had 100% disability with MS. So when we're looking at this blue graph here, these are the people who had been on the escalation therapy, and the yellow graph here is the patients who had been on, highly early intensive therapy. Early intensive therapy does not, necessarily mean induction at the first place. It means that, probably I am not going to just follow this A, B, C, D, and I may shift from A to X. So that is early intensive therapy. So clearly it is seen that those who had clinically, according to the decision of the clinician, probably an escalation of therapy at an early stage did fairly well as far as the disability is concerned over the years of MS that they had. So the outcomes were more favorable. So now if we practically think about starting somebody on a highly efficacious therapy, it probably would be a first line for a moderate or a severe MS. Second line when orals, injectables, or other highly effective therapies fail. And probably I will talk about this bit also, more used for pregnancy planning. So other than these anti-CD20 monoclonal antibodies, there are a lot of other drugs that are coming into the pipeline. There are phase 3 trials, there are post-marketing trials going on, and I'm going to only name them because there'll be a lot of confusion otherwise. And the second important thing is they're just now not available with us in India. So this is your anti-CD20 group. Then you have your S1P modulators. Then we have this group that is the cladribine, and the newest ones that are there is the proton tyrosine kinase inhibitors. But all of these are still not available with us other than the anti-CD20, your teriflunomide, your alemtuzumab. All right. So to put it in a nutshell, for the newer drugs in MS, there's a favorable benefit to risk ratio and they're generally well tolerated. Comparable rate of side effects, if you compare them with your older drugs, that is interferon or teriflunomide, easy to manage during pregnancy, and even if there are some infections, there are risk mitigation strategies which are available. So going on to the second part of our talk, that is pregnancy and MS. So we all know multiple sclerosis is more prevalent in women of the childbearing age. So when we consider men vis-a-vis women, women are at least 2.5 times more likely to be diagnosed with MS. Now, when we see women with MS, majority of them would be in the childbearing age, because those will be, in the age bracket of 20 to 45. So if a lady has MS, she's in the reproductive age group, and there are so many questions once a patient gets diagnosed with MS. That initial phase of why me and why did it happen to me, then goes into a transition with, okay, I am living with MS, but I am going to live a good life with MS. And then there is the second question that comes for young ladies nowadays. Doctor, do I get married and will it affect my married life? And what if I get pregnant while I'm having MS, while I'm at DMTs? So the first question is, what effect will a pregnancy have on my MS course? What effect will my MS have on my fertility? So will it be that, my fertility will be affected, or it will affect my baby? What steps should I take before getting pregnant because of the MS that I have? How should my MS be managed while I'm trying to get pregnant and when I am pregnant? And how should my MS be managed during my labor and after I have given birth? So the important question of breastfeeding. So this was one of the, landmark trials that they looked about in pregnancy babies. That's the PREEM study. And if I have to put it in a nutshell, what is the results of the PREEM study? Relapses usually return to pre-pregnancy levels 4 to 6 months postpartum. Then if a mother has had a highest pre-pregnancy disability and relapse rate, she is more likely to experience postpartum relapses. But the most important take home from this was that pregnancy has a little to no impact on a long-term prognosis of MS. And there is a marked disease activity which is often observed in the third trimester. So by far, if we have to probably take two take-homes from this trial, it was that pregnancy is a relatively safe period for patients with MS. If pre-pregnancy, a patient has more disability or a recurrent relapses, there are more chances that post-pregnancy, this lady will have a chance of a relapse. And usually, if there is a relapse during the pregnancy, it may not be that severe. So then they looked at what are the perinatal characteristics and obstetric complications in mothers with MS. So let's not go into, but as we see, there are huge number of pregnancies and huge number of babies with MS that were studied in this study. And what conclusions they had was that women with MS do not appear to have an increased risk of any neonatal complications. Neonate, I mean to the baby. Women with MS do not appear to have an increased risk of obstetric complications. Obstetric, I mean complications related to pregnancy and labor. And babies born to mothers with MS were similar to other mothers. Now the next question is breastfeeding. So when we have this breastfeeding, the decision of whether to breastfeed or not is very challenging, because the mother may be worried that what if I pass on the drugs to my child? Is it safe for the child to take the drug because I have MS? And if I start breastfeeding, will my MS activity get reactivated? So, there is usually a neutral or beneficial effect on the annualized relapse rate while you are breastfeeding. So the available evidence says that breastfeeding is safe and probably even beneficial for patients with MS. So there are two very good articles from the Practical Neurology where I am going to show cartoons from them, where they have tried to see how we could manage a lady while she's going through her journey from pre-pregnancy to postpartum. So when a patient is planning a pregnancy and she comes to you to the clinic for the first time, what is important to re-emphasize is that there is no effect of MS on the fertility. Don't routinely defer DMT just because the patient is going to plan a pregnancy. Consider effect of exposure in males. This is important for males who have been on certain DMTs like your teriflunomide, where even if the father has MS, there can be some transmission of the drug through the semen and the baby may have some in utero problems. Then, pregnancy does not affect the long-term disability outcomes in MS, and the relapse risk during and after pregnancy has to be clearly explained to the patient. Now, if a patient with MS is pregnant, there is absolutely no difference between her and any other lady regarding the whole pregnancy period. So it's automatically not a high risk case. And if you have a relapse during pregnancy, you can safely be given IV methylprednisolone without any effect to the baby. Vitamin D supplementations are recommended, and if the patient has MS, it does not mean that she cannot get a spinal or an epidural anesthesia and she has to always go for a general anesthesia. So these decisions of risks during pregnancy, what type of mode of delivery has to be chosen for, is usually depending on the gynecological considerations and not because of your MS. And postpartum, obviously, breastfeeding has been very effective. So it is very essential for the child and it is rather protective for the mother. So we usually do not deter from breastfeeding but support breastfeeding. Again, during breastfeeding, if the mother happens to have a postpartum relapse, methylprednisolone is not contraindicated. Okay. And if the mother has not breastfed, there could be some risk of postnatal depression. Let's not go into that. So if I have to give a snapshot of different drugs and their risks and what considerations we need to do while they're given in the pregnancy in patients with MS, this is the picture, but it's too complicated. So let's go step by step. We're talking about the first line drugs and we're talking about orals and injectables. So when a lady becomes pregnant and if we need to give injectables to her, and so if we say which drug is the safest in pregnancy, the answer is your first line injectables. You can continue it safely till you conceive. Even if you continue it during the pregnancy also, there are no risks that are seen to the fetus and probably even for the pregnancy outcome. Pregnancy outcome, I mean stillbirths or abortions. Okay. Now, when we stop it before pregnancy, it is ideal to restart within 3 months postpartum. And even while the mother is on interferons in the postpartum period, generally it is very safe to breastfeed the child. So to put it in a nutshell, there is no evidence of harm to the fetus, probably the safest of the injections. When we're looking at teriflunomide, the stronger the drug, probably the more the side effects. So here, what we have to remember is that it is teratogenic. Teratogenic, I mean to say, it can affect the baby in utero. So when it affects the baby in utero, we have to be careful. So if there is a young couple, if the girl has MS and she's been on teriflunomide and she wants a pregnancy, we generally say that there should be at least a 2 years washout period. Or if they want probably to conceive earlier, then what we have is called as an accelerated elimination. And mind you, even if the father is on teriflunomide, there can be still some issues with the baby. Now, in that sense, dimethyl fumarate still has a limited data, and the guidelines say that breastfeeding is generally contraindicated while you're on dimethyl fumarate. Going on to the highly effective drugs, your natalizumab, alemtuzumab, fingolimod, or your cladribine. So what we have to remember is when somebody is on natalizumab, the patient already has a very highly active disease. So we go back to the same statement that if the risk of relapses and the disease disability is higher before pregnancy, you can have a higher risk of relapses after you stopped it during the pregnancy period. Then the second one is the highly effective therapy, that's your alemtuzumab. So generally when you are on alemtuzumab, they say that you need to wait for at least 4 months to a year before you plan a pregnancy. And the other important thing is that you have to monitor for autoimmune diseases during the pregnancy. Then the cladribine, which is not still available with us in India, please note that it is very teratogenic. That means even if the mother or the father has MS and has been on cladribine, it can affect the baby. So we have to avoid a pregnancy for 6 to 12 months after the treatment course. Going on to the anti-CD20s. So they say that we have to avoid a pregnancy at least for a year before planning a pregnancy while you are on anti-CD20 therapies. But when you wish to breastfeed, it should be encouraged as soon as possible. Though, they mention that breastfeeding is contraindicated, there are more studies in real life to say that it is relatively safe. The only thing that has to be kept in mind is that there can theoretically be a risk of B cell depletion and some sort of blood issues with the infant, but these are also very transient. So, going on to these anti-CD20 therapies during pregnancy and breastfeeding. So, in the preconception period, you can still safely start the patient on anti-CD20 therapy. When we plan a therapy and then plan a pregnancy, there should be at least a gap of 4 to 6 months before you plan a pregnancy while you are on an anti-CD20 therapies. While you are pregnant, if there is a need, there are some experts who say that you could still take. So, there are strategies in which what people do is that just before you plan a pregnancy, you have to take a dose of your anti-CD20 and then cover the whole pregnancy. And once the pregnancy is over, probably give the second dose as scheduled. Always remember that because these are higher drugs, high efficacy drugs, the mother has been a little immunosuppressed. So there is some chance of the drug going through the breast milk. So if the baby is born, then there will be a relative risk for infection. So live vaccines are avoided in the babies who are born on mothers with anti-CD20 therapy. Also, if the mother is pregnant and she has to take any vaccinations, she should not take these live attenuated vaccines. Now, so if we put it as take homes from these recommendations, they can be safely given to women wishing to get pregnant. Now, women can safely start trying to conceive without delaying further following the anti-CD20 therapy. And women with RRMS, there's an increased risk of relapses in the postpartum, so prompt retreatment may be started. In breastfeeding, they said that should be encouraged if we go alongside the therapy assumption. And as I mentioned again, live attenuated vaccines have to be deferred. So if we put it as 3 take-home points for pregnancy in MS, pregnancy is a beneficial state for patients with MS, both long-term and short-term. Children born to mothers with MS are typically healthy. And women who wish to get pregnant should always be counseled regarding the benefits, risk during pregnancy, postpartum period, and how do we place our disease-modifying therapies and what effect the disease-modifying therapy may have on the fetus in the uterus. So the take-home from today's talk is that therapy of MS are evolving. Novel therapies with high efficacy are available, but we have to tailor therapies. So there is no one answer to anybody's question. Also, there is no one choice, but these are multiple choices which have to be a permutation and combination, and there has to be an active involvement of the patient in the therapeutic decision making. Children born to mothers with MS are typically healthy, and prevention of fetal exposure to DMTs with thorough counseling is essentially important. Thank you very much.
Thank you. It is really nice to hear from you, Varsha. And thank you for explaining the treatment, especially the new modalities. I remember when we were students and we were told about the, what they used to call the hot bath test for MS. Okay, I mean that was the Utah phenomenon, where if the MS patient was put into a hot bath, his neurological symptoms would worsen. I mean, from that day to today, there's been such a good and wonderful progress in the research being done on MS and the development in the treatment as well. And now you have told us about CD20 antibodies to CD20, which really make a lot of sense to us because rituximab is one drug which is on our a national essential drug list, and therefore the pricing of that drug is in a restrictive mode. We have questions in the chat box where they're asking about if there wasn't a financial factor, then what would be the difference between rituximab and the newer therapies? And is it, can they go straight to the newer therapies? And another thing is that, of course, you have given us a beautiful, very nice insights and inputs on pregnancy and when DMTs should be stopped, when pregnancies can be planned, and how even if postpartum the person does relapse, methylprednisolone can be started and will not affect the baby. So breastfeeding should not be stopped. Thank you so much, Varsha. If you can see the chat box,
Yeah.
then there
Yes,
are
madam.
some, yeah. So if you could just, probably answer that.
So,
See,
going
one of
on to the first.
yes, one is about, of
Yeah,
course.
madam, can you hear me?
Yes,
Yeah.
I can.
So obviously, this is the most pressing factor that comes to our patients, the cost of the therapy. And there is no denying the fact that there are no insurances which cover up all the therapies. And then practically, if I tell somebody that you have to take a therapy probably for a few years from now without giving a timeline, the first question would be how, cost effective and how costly would be the therapy. So, laptops.
Hello?
Yeah, madam, can you hear me?
Yes,
So,
I can.
yeah. So, without quoting any brand names or anything, if we go at the MRP of the first, and if we look at the yearly costing of probably rituximab versus the other drugs, there would be at least 1.5 times difference between rituximab and ocrelizumab, and maybe at least 2.5 times between rituximab and ofatumumab. That's one. Second thing is obviously there are biosimilars available. So depending upon what is probably the cost that could be borne by the patient, the therapy can be decided. So there cannot be one single figure that probably I can quote here, but I'm just giving a broad difference between the three therapies. Now, when you compare that to probably,
Sorry,
yes, madam.
please go ahead. Yeah, please go ahead.
Yeah,
Please
and
go ahead.
I would probably say that if MS Society of India can help patients in this front, because Madam Chitnis and Mr. Sandeep Chitnis
Yes,
has been a big advocate for patients with MS, and they've been probably going at even higher authorities. And if we can get it in the essential drug list, and whether there can be a subsidized cost that patients can bear while having multiple sclerosis
we are
therapies like
advocating
rituximab.
for that. We are advocating
Yeah.
for that.
Yeah.
So I just wanted to ask you, Dr. Varsha, that when you prescribe DMTs in a young woman, okay, or a young man, from what you have told us, though newly married, do we have to take, because now there is this huge issue about consent forms, so do you have to take a consent from them about knowing that these drugs are, about how long they can be used, when can a pregnancy be planned, and all that rest of it?
Mm-hmm. Right, madam. So, in this particular aspect, madam, I would say that since today is the age of, probably no more the doctor-patient, but a little bit of, medical legal issues and all of that, I would say ideally, yes, consent should be taken, because we do take consent for most of the important drugs that are given to the patients.
Correct.
So, if you go back to what I was talking about, whenever we start therapies for anybody, the most important thing is the dialogue between the patient, the family, and the doctor. So when I mean a
Absolutely.
dialogue, it means that understanding what are the pros and cons of a therapy, understanding what could be possibly the timing when we could start the therapies, and also understanding the implications or the future implications of the therapies. So in that sense, I would say
True.
yes.
Very true.
Yeah.
One of our patients, unfortunately, had a
Mhm.
very aggressive lymphoma part, after starting, yes, a DMF. So, I mean, how often have you seen this? It's a known complication, but how often does this really happen?
Madam, this is again quite rare. So if you go through the
It is,
literature, yeah, it is very rare.
yes. So I don't think the rest of our
We
MSP should
practically
be
are
very,
talking about, but if you look at the European or the American guidelines, they do also mention about this therapeutic, theoretical risk of probably even PML while starting somebody on dimethyl fumarate or probably starting on some other
yes.
immunomodulatory therapies,
Yes,
as I would
yes,
put it.
yes.
So that's what I said, the dialogue and preempting patients is most important. But if you ask in the real life, we've really not seen patients having a PML just because they are on dimethyl fumarate. These
Very true.
studies
But
about
Dr.
rituximab
Varsha,
and malignancies and PML have also
yes,
come from the other specialties, because rituximab,
true.
for that matter, has been in use, rather was first for the treatment of lymphomas.
Yes. It's
And
an
then, it went
antimetropolis.
into
Yes,
the rheumatoid arthritis and other
yes. These are all the life
neuroimmunological
extensions
disorders.
of the drug. Yes.
So these patients are already immunosuppressed, and then probably if we get, but even in the literature review that we did for even our article or even the talks that we give, it is quite safe, and the risk of PML is really, really, really minimal if we have somebody on anti-CD20. In fact, those who are on natalizumab and who had been JC virus positive, we've been able to safely shift them to rituximab.
Okay, that's lovely. Now,
Yeah.
really, because we're in India and we really should be asking this question, how often do you see tuberculosis, recrudescence, or, I mean, what is the
With disease
scenario?
modifying therapies, right, madam?
Yes, yes.
Yeah. So again, there are a lot of factors here. So when we start somebody on, highly effective therapies, we emphasize on these three things, what we call as risk mitigation. So, I have also been, and proponent of vaccinations before we start anybody on, highly effective therapies. That's probably some bit I'll cover later. But going on to your question on tuberculosis and rituximab or other highly effective therapies, yes. So the patients are theoretically at a risk of probably a reactivation or recrudescence. But when we saw in our set of patients who were on rituximab for even 10, 15 years, we have actually not found a patient with TB as a complication after starting therapies. Though my colleagues
Wonderful.
from other
Absolutely.
centers do mention about the risk
Yes.
of rituximab. So a lot of it is also to go into the socio-economic status and probably the general health of the patient.
Yes.
So
Yeah.
when we start somebody on rituximab, we do look at the chest X-rays and the other markers for tuberculosis, along with emphasis on vaccinations for commonly preventable diseases, as your influenza, your pneumococcal, shingles, and young ladies in the in the reproductive age group, even the human papilloma virus, the HPV vaccines.
Yes. Yes. That's great. Then coming to pregnancy, of course, you've given a wonderful discourse on that. But if you find that that patient had has had all these DMTs, or like you even now, as you have shown us, that even if the male partner had taken it, and for any reason the pregnancy has to be terminated, uh, what are the precautions we need to take in an MS patient?
So, madam, generally there will be no great differences between any other medical termination and a pregnancy in a patient with MS. So, if I could, there are proponents. So, I had been to a meeting where there was Dr. Kirstine Hellewick. She's a big proponent of pregnancy, and she is very much interested in these registries on pregnancy and MS. And definitely, one thing that she did say is that largely, we could probably prevent abortions in patients with MS if they have an accidental pregnancy, except when a pressing need. So when we say a strict no to which drug probably was there pre-pregnancy, teriflunomide is one drug which is really toxic. So if somebody has a pregnancy while they are on teriflunomide, the answer is please terminate the pregnancy because it has long-term complications. We would rather be, unhappy rather than be sorry at the later stage if the baby is affected. So then in the other scenario where the lady is probably on teriflunomide or the husband is on teriflunomide, and they want to conceive. So in this case, usually what we have seen is that we have this accelerated elimination. So what accelerated elimination means is not IV drips, but certain drugs that we give so that the drug is eliminated quickly from the body.
So that itself will help in the future. Yes, I think the chat
Other
box,
than
I
that,
think,
if they looked at practically somebody on natalizumab or anti-CD20 therapy, if we really go by the book, then we should definitely consider. But again, in the two groups, anti-CD20 is still safer. Still safer. I mean, whatever risk to the baby are usually more theoretical than practically seen. That's one. Natalizumab also. So when they looked at their cohorts and when we look at real life, scenarios, again, they are saying that the risk of anomalies in the fetus were quite less when there was an accidental pregnancy versus, there was a planned pregnancy. So again, but this decision of to abort or not to abort is again a joint decision. And, it is probably the mother's and the father's decision to go ahead or not go ahead.
yes. Thank you, Dr. Varsha. That was wonderful. So I think you must give some very strong messages that pregnancy could occur. Now, I think there is a message here that, about MS patients being a little diffident about getting married at all, see? And their symptoms like spasticity and things like that, whether that in any way,
Yeah. So, madam, now, so in the clinic, there can be very, very interesting interactions because everybody is not same. And if you look at girls, probably there is a sea change on how girls look at, their life, their career and everything else. So there's often this question, doctor, I'm suffering. Why should I make somebody else suffer? That's the first thing that, some of those girls come up with. Then the other group that comes up with is, okay, maybe, but I also need my career to be in place before I think about the pregnancy. And then why, go through all of that. So my answer to this group of patients is that we need some support. And if we need a support, then marriage is probably a lifelong commitment. And in the Indian community, it is so strong that if we consider to the West, this is probably the most valued cultural aspect that we have in India. And so if a young girl comes to me and if the parents, if this is a girl in 60s and 70s, I do explain to them that, look, this is not something that is going to limit her life. This is not going to affect her reproductive phase. This is not going to affect the decision on whether she should get married or not, decision whether she should have babies or not. It's quite safe.
This actually brings us to a very age-old question. How can one actually predict that if there is one MS patient in a family, Now we know there's no genetic markers, or are there? In the latest, I would. But autoimmune, tendencies can be there and could come out. So these are the fears that even though we have these big, huge banners that we tell people it's not contagious, it's not genetic, it's, doesn't run in families. These are the questions that we as a support group, we are facing these questions. So we have you here on our platform. So please let us know what is the actual, I would say, place of multiple sclerosis as a disease in the population. I mean, how would it affect people? Can it affect others? If you could just tell us a little bit about that.
So, madam, this is not contagious. This is not contagious. This is probably, even if you look at the genetic aspect of multiple sclerosis, there are some studies to say that HLA correlations, or those figures that people quote, because they're looking at population as a whole. So even in monozygotic twins, that means twins who are of the same bloodline and same sex, also there is a difference in the tendency to have MS, and it is a lot also to do with what external factors. So when we discuss about it, and I hear from my bosses, then there is the story of two twins who are girls, and one is in India and another has got to Europe. The one in the Europe gets the MS and the Indian doesn't get. So even if I have a genetic predisposition, there are so many other factors that matter when we look at somebody getting an autoimmune condition. Then again, if the mother has MS, there is still quoted a figure of at least 2 to 3% where the child may have MS. But if we look at, again, population as a whole, these are like huge, big group of populations and registries. It is, I would say, such a small number that,
very minuscule.
We should not deter you from,
Yes.
But
it shouldn't,
if
in
both
fact,
parents
be
have
a
MS,
factor that.
Yeah. But if both parents have MS, then I would say yes, there is more likelihood that there may be an autoimmune issue in the child.
Right. Thank you so much for that, because that was, something I would say outside the textbook,
Yes.
But but this is your experience talking.
Yeah.
So,
But
that's
again,
wonderful.
textbooks and real life is so different.
Absolutely, totally.
Now, this
And I
question of
support
when to stop the therapy. So if you go by the textbook, it says don't stop till the patient is 55. He or she has not had any clinical disability or relapses. But so often in our group of populations, sometimes it's the patients who just decide that they want to stop the therapy. So in such cases, we say that, if it's a severe or a relapsing disease, I would say be cautious, because then you may land up in a more severe relapse if you suddenly stop to a therapy. If somebody has been having a mild disease, then usually it may not be that harmful. Again, I often hear from Dr. Singhal talking about this, and he says that Indian patients are slightly different from the European or the American cohort, and our patients seem to have a little milder disease than those from the other population. So there's a lot to do with our genetic makeup as well.
True, very true. Now, just while we're talking about this, can MS actually go undiagnosed? I mean, we don't see the projected population that in India that should be having MS, the projected population. And, the actual registered, or even in the disability registry and the support groups and all, the neurological, the neurology associations talking about it, we don't seem to be. I mean, is it possible that there is MS, but for a very long time it is undiagnosed?
Can happen, madam. So actually, education, information is most important. Then also that probably now my generation of neurologists is a little more tuned to the fact that there is MS in India. So we are on lookout. So the amount of diagnosis that is happening, the number of people who are newly getting diagnosed is much higher than what was probably in the past. But we are still a country where there are so many disparities. If I look at a young girl from the rural background where, basic amenities like water and electricity are a problem, the lady may suffer for years and nobody would know.
Yes. And the early symptoms of fatigue and all this, they're not really counted as something to be investigated, I guess. That is also there. Zaved? Hello.
Yeah, Dr. Rekha.
Yeah. So Zaved, just alert me as to when you need to wind up the session. Okay.
Yeah, so we have time till 1:30. If we have more questions, we may take. Otherwise,
Okay,
we may
wonderful.
wind up.
Then can we open up
Yeah.
the floor? Because they're not really typing it into the chat box. So
Rahul has raised his hand.
okay, fair enough. Then let Rahul speak.
Hello, ma'am. Actually, I had two episodes or relapse. I don't know. On while using it while under rituximab, third relapse it's like C2D11 lesion. Fourth relapse is C7. So we have to switch the high to higher efficacy, or can I still continue rituximab? Hello.
Hello.
Is my voice audible, ma'am?
Varsha, are you there?
Hello.
Can Rahul repeat his question?
Yeah, ma'am.
Rahul.
My doubt was that actually in my 5 years of with MS, I had four episodes. So in my third and fourth episode, na, I mean to say relapse, flare up. Third and fourth flare up, na. Third one I had C2D11 spine na, lesion. Fourth one C7 compared to previous MRIs. So so as per your expertise now, we can continue. We have to go for high efficacy drug. I can walk. Nothing to worry. So I can continue Dixon or you have to switch to high efficacy. Huh? Third one C2 Dillons, fourth one C7. Okay. Hello, ma'am.
Dr. Varsha?
Dr. Varsha, you are not audible. We are not able to hear you.
Just a minute, let me just check. Can you hear me now?
Yeah, audible. Can but if you don't mind, could you speak a bit louder?
Can you hear me now?
Yeah, now it's far better than the previous one.
Yeah. So how many years have you been on rituximab?
Rituximab from past from June 2022.
Mm-hmm.
After my second relapse, they switched me to from dimethylphenidate to sorry, I want to say to rituximab. They switched me. They give me two
Right.
options: Tisabri or rituximab. Tisabri is beyond my budget, so I switched to opted for rituximab. So while under rituximab, I had an episode on third episode on C2D11, fourth one on C7. So I don't know whether it's a pseudo relapse or Utop's phenomenon. So we have to switch for high efficacy, or can we continue on rituximab? That's what I thought of asking. Hello, I am unable to understand. Hello.
Dr. Varsha, not audible, not at all.
Okay. I don't know from my
Hello.
side problem. I don't know.
Mhm.
Dr. Varsha, can you come closer to the mic? We are not able to hear.
Yeah, just a minute. Can you hear me now?
Ah,
Perfect.
Now it's
Perfect.
far better. Far better.
ah.
Yeah. So, what I would say is that probably you continue rituximab for now instead of, jumping into a little higher efficacy therapy just now, because radiological markers are not compelling for you to go for higher induction therapies just now.
Okay. So, and one more thing is like, till how long we can be on rituximab? I don't know what are the guidelines and all that.
So unfortunately, the answer to this is also not there in the literature.
No, I till how long you can use rituximab? I'm just asking. My doctor always recommends Trisabri, but it's beyond my budget now. So, I thought, I thought of
How
asking
long,
whether we can. Okay,
how
fine.
long question that you have asked. So
No,
I would,
for how many years I can use rituximab?
yeah, that's what I'm telling you. I'm trying to answer your question on that end.
Okay, sorry.
Yeah. So theoretically, there is no answer to when to stop.
Okay,
But we've given patients rituximab for at least 10 to 15 years now without any major, issues.
okay,
The only two things that, usually what we are worried about is when, the immunoglobulin levels go down, okay, what we call as
okay,
hypogammaglobulinemia, there is a little issue because then
okay,
you are prone for infections, okay,
okay,
and
okay,
probably vaccination status. So if the immunoglobulin levels are well within range and there are no compelling infections, you could still take it safely for, a few more years from now.
okay. Yeah, my doctor always checks my IgG levels, CD19
Ah,
before.
Yes,
जा
that,
पटकन आता जा.
Hello.
yeah.
Yeah, actually,
Yes.
yeah, my while recommend next dose of rituximab na induction, he will check my IgG levels, immunoglobulin levels, and CD19 before giving me rituximab. And one more thing is like, is phase 3 BTK inhibitor trial safe, ma'am?
Can you,
Okay, I think
Rahul?
Rahul,
BTK.
So
I think these are the question you can ask
yeah, so
direct question.
and I
Yeah,
think
because
what I,
it will be
yeah,
very difficult to answer by doctor if you will ask
Okay,
lengthy
yeah,
question.
no.
Fine.
Now,
I'll
It's
do
Javed
better if
it.
you
is
have
actually,
ask direct
no,
question.
Javed, actually, Rahul has brought up a very nice part
Hmm.
of this whole thing. What, is that Varsha, Dr. Varsha, when
Can you
would
hear,
you,
madam, now? I think there was some technical
yeah,
issues at my end.
can you hear me now? Can you hear
Yes.
me? Okay.
Yes.
So a question has come up, I mean, from all this discussion that when when should it be, as a support group? And a lot of people do come to us saying that, there is a trial going on, a drug trial going on. And they come and ask our members come and ask us, ki, should we go on to the drug trial? So just tell us a little, how are people inducted into these drug trials? Because everybody wants to be a recipient of the latest and the newest drug. But,
Yeah. So, madam, when we talk about putting somebody in a trial, we have to understand that sometimes trials are blinded. That means they could be double blinded or they can be single blinded. When I say double blinded, I mean the doctor doesn't know and the patient doesn't know what he or she is getting. So this,
so
when
it could be treatment against a placebo. I mean, is that it? Treatment against a placebo?
treatment against a placebo, sometimes treatment against the unknown therapy. So that's
Okay.
one thing that we need to know. So when somebody is to be inducted in a trial, the idealist way is to give what we call as the information sheet to the patient, where everything is explained to him or her in their language that they best understand regarding the therapy. What could be the possible implications while they are on the therapy, and some trials obviously also have what compensation would be given to the patient while they are on the research trials. Now, it is again an individualized decision. Nobody can force a patient to be in a trial. It has to be an informed decision making between the doctor and the patient. Say, so tomorrow I have been approached by a It's usually pharma funded. So some pharma has approached me for trials on the Bruton tyrosine kinase inhibitors. So if I do agree for it, it doesn't mean that I have to force a patient to be on that. They have certain criteria as to what could be the patient profile. What are the different characteristics? So does the patient really fit into those characteristics? And lastly, is the patient willing to be in the trial? So the question of willing to be in
Because
the
once
trial is answered if the patient knows what he is going to go through, including what could be the beneficial effects, what could be the side effects, and what could be the implications of not, being on the therapy. Because at the end of it, patient shouldn't feel, like, oh, I wanted to take the new drug, but I was never given the new drug. We need to know what kind of trial it is.
Very true. Because quite often it is a trial is seen as a introduction of a new drug, and not everybody being, privileged enough to get it, which is frankly not the case. It is after all a fact finding
I would rather say
mission.
we are more grateful to patients that they choose to be in the trial rather than the doctor
True.
saying you have to be there, because it is
Yeah.
their choice that you have to make. But it is also, if the question is that if nobody agrees to be in a clinical trial, then how would we ever know that the drug is effective?
Yes.
So I would say that it will be again an informed decision and ultimately the patient's choice, because every trial says that patient has a right to discontinue from the trial at any point. This is always there, and there are so many ethical issues that come up even before a trial is started. So I would say that if a patient profile is matching, the patient is willing, I wouldn't discourage the patient from being in a trial, because he or she has been brave enough to be on the trial. And unless we know somebody is ready to, probably take the wish ration and become a Nilkant, that we can know whether the drug is working or not.
Thank you so much. I think that was really nice, because this is always a question that is left unanswered, and it does matter to a support group, because people do come and ask about different trials and things like that. What about tests, Dr. Varsha? Is there any progress in diagnosing MS?
Yeah.
Is there beyond the
So beyond the MRIs and routines, so I would say solid markers still remain as your MRI and the CSF markers. These are probably still going to remain at the center of the diagnosis. A lot has been done. Now there is another revision of the McDonald's criteria, where researchers worldwide are trying to see how earliest I can diagnose MS. But there are some very exciting biomarkers that are coming up, especially those higher definition MRIs, even blood and CSF markers like your neurofilament light chain assays, which have a promise. Though practical application may take a few years hence. There's a lot being talked about ocular computed tomography, OCTs,
yes,
in predicting progress and predicting relapses in MS. So I would say the field is getting more exciting, and probably the more research that we do, we will definitely have some more markers to be sure.
yeah, that will be really good, because the quicker, the simpler, and methods, if tests were to come in, it just makes it better. And the last thing that I would now want to ask you, Varsha, all your, right since you have started, as a student, as a postgraduate, as a faculty member of neurology, uh, has there ever been, where we could say, yes, this is the first sign or symptom of MS? There was this whole discussion on headaches being the first symptom of MS. I mean, is that true? Are we looking out for early signs of MS? I mean,
So, madam, again, I will say headache is the commonest symptom that we get in our outpatient. So it doesn't mean that everybody who has headaches is prone to MS. That's a big, big misnomer. Again, very interestingly, patients with migraine also have white spots in the brain, what we call as unidentified white spots. So that should not make somebody think that this is MS, because once in a while this has happened, that there's a young girl with headaches and those white spots are mistaken for MS. And she's come with a panic, and all we have to do is relay her and say, look, you don't have MS. And if you ask me, the important symptom is optic neuritis, because that's probably the commonest and the most common symptom that a patient with MS has. Of course, depending on what parts are affected, but if I look at say 150 or 200 patients, optic neuritis still will be the most common symptom that will come to the clinic. So if a young
and a red
girl
flag.
Yes.
And it's a red flag for
It's
all the faculties across the medical
Yes.
field. I mean, optic neuritis is not something that anybody should be.
Yes.
taking
So,
like.
in fact, our ophthalmology, we're blessed with a very good neuro-ophthalmologist. So, there is this general debate on whether an optic neuritis is to be treated just by the ophthalmologist or neurologist. And he comes up with say that I have to be in sync with my neurologist if I have to treat optic neuritis. So, if somebody is going to an ophthalmologist, you will not get the full perspective of what you are dealing with. And then there can be a delay in the diagnosis.
So that really
May I
leads.
ask one, Rekha, I would
sure,
like to
Sheila.
ask one question after you.
Okay. No. What this actually means, Sheila, is that the medical field really needs to talk to each other, the faculties.
Yes.
The approach to any and every disease today, my feeling is it is a multidisciplinary disease. And we
Yes.
need to talk. Like we had the whole team of urologists in today. I mean, it's a part. So even the neurologists need to talk to them, and like what Dr. Varsha says, ophthalmologists. So it's
Ophthalmologist.
actually, any chronic disease should be tackled by a multidisciplinary team. I think that really makes a lot of sense.
That is what we
Sheila,
try
go
to
ahead.
create, no? That is what MSSI
Oh,
try to
yes.
always creating with
That is our premise.
free medical camps where all faculties, whatever we can
Yes,
get,
yes,
whoever
yes,
get involved, that is what
We
we are
are,
looking
that's
for.
true,
And
that's true.
MSSI is for that only. That is the role, main role of ours.
Yes.
And Dr. Varsha, I would
And our
like
camp
to
is coming up.
how many MS patients you are seeing? I mean, what is the percentage approximately? They monthly, daily, or yearly? What is it? Because another side question, I mean, request is that whenever you get MS patients, please let them know about the society.
Definitely.
How you would like to do that? Shall we send maybe uh, something notice to put on the board or some literature to you? But please inform, because patients come very after much, and then there, as you say, we are giving lot of things free also, and we can connect them to the different doctors also. So this is what I would like to
Madam, I have known
truly
MSSI
request from my
ever
heart.
since I was a student here in Bombay Hospital. So
Uh,
obviously there is no need for
True.
you're always there
True.
in my heart.
You have. That's why I said you're one of our neurologists. Hakkani म्हणतो आम्ही. You're our neurologist. Yes.
And you are
Yeah.
going to start a MS clinic also, no? Dr.
Yes,
Khadilkar was
very
mentioning.
soon. I mean, under the
Ah,
guidance of Dr. Khadilkar and other faculty in Bombay
yeah.
Hospital.
Oh, wonderful. Great.
And
That
we will
will be
need
great.
full cooperation from the MSSI for that.
Yes, that will be great.
Yeah.
Thank you so much from my heart.
Thank you,
And
Varsha.
it-
It was a great pleasure
Pleasure
to.
for me too.
Absolutely. And Sheila, would you like to say a few things?
no, I would like to thank her with bottom of my heart. She came. Actually, only one day she is getting rest, and that Saturday today you are very busy again, no? So
Yes.
I know you have taken time off. staying so far away. So virtually it is possible, mainly possible with you. No, that's the thing. We would like to have you for our medical camp also, but I know it is not possible. So thank you, Varsha, and
Thank
get
you, ma'am.
involved with us continuously.
Sure.
That's the request.
Thank
Thanks.
you, ma'am.
Thank you so much, Varsha.
Thank
And I
you.
would like
Thank
to
you,
thank
everyone.
all
Thank
our
you.
participants, everyone, and for so proactively asking questions and, seeking advice. Thank you so much, because that gives the MSSI also, the Mumbai chapter, a lot to think about. And, we can also improve on what your expectations are and how to fulfill them. So I think that's wonderful. And thank you for coming today.
Shall we close the
Shall we?
session now?
Yes, I think so.